colleagues. My name is Dr. Nadia. I'll be taking question 451 to 460. So I'll start with the 451. So the question reads as follows. A 57-year-old woman comes to your office because of 6 months of fatigue, weight loss, and periods of tachycardia, flushing, and diarrhea. She also describes vague fullness in her neck. Examination discloses clear lungs, an irregular pulse, distended jugular veins with a prominent V wave, a holosystolic murmur at the lower left sternal border that intensifies with inspiration, and peripheral edema. She's afebrile. The likely cause of her illness is, so the options are A, bacterial endocarditis, B, carcinoid syndrome, C, Epstein's anomaly, D, chronic pulmonary embolism, and pheochromocytomas, E. So let's start eliminating the options. So bacterial endocarditis, we know that there cannot be bacterial endocarditis, even if it's subacute, there should be some history of fever, of which we're very clear that she's afebrile. So we're going to cancel out that option. If we go to Epstein anomaly, so this is a 57-year-old woman. So fine, some of the signs here might be pointed to Epstein's because of the fullness of the neck and all that. But still, she's still too old to be presented.
Okay,
congenital heart. So I'm going to leave out Epstein's anomaly, which is a very strong differential actually in this patient. Then we have chronic pulmonary embolism. Very clear here. They said she had clear lung zones. So we're going to pull that away because she already has right-sided issues here because of that prominent V wave. That prominent V wave is showing that she has most likely severe tricuspid regurgitation. Then we'll go to pheochromocytoma. Pheochromocytoma is also a strong differential here because of the tachycardia, the flushing, and the diarrhea. Even pheochromocytoma comes with diarrhea, but there's a triad of pheochromocytoma which has headache, yes, headache, and that's a very, very strong presentation of labile blood pressure. They didn't mention anything about the blood pressure, which is very common in pheochromocytoma patients. Besides that, and they also have a lower frequency of flushing in pheochromocytoma compared to carcinoid syndrome. So pheochromocytoma is a very strong differential here, but that's not the likely answer because she didn't have any headaches and labile blood pressure that was not mentioned here. And pheochromocytoma does not present with right-sided issues. So our differential here is carcinoid syndrome. So what is carcinoid syndrome? So carcinoid is endocrine malignancy that leads to diffuse deposits of fibrous tissue on the endocardium. So how this happens is that there's hepatic metastasis, which is now releasing into the blood at the IVC, and it goes to the heart. That's why it affects mostly the right side of that. So that's why we can see some of these changes that have led to right-sided issues, which include her prominent V wave. We all know what the V wave is. The V wave is filling of the right atrium, and that is, if she has a prominent V wave, it is mostly in keeping with a severe tricuspid regurgitation, which is pathognomonic of carcinoid syndrome. And she also has distended JVP, which shows that she has increased pressure on the right side of her heart. So carcinoid syndrome is our diagnosis here, but there are other things that can cause right-sided issues. We can have a functional TR, which can say as consequence of pulmonary hypertension, which can come from death in the pulmonary hypertension patient or pulmonary. You can also have masses also in the right side of the heart also that cause tricuspid regurgitation. And also there are some drugs also that can cause valvular damage to the right side of the heart that can lead to tricuspid regurgitation. So carcinoid syndrome B is the answer. Please, I'll take comments, contributions at this point before I move on for 5-2. Comments, contributions, going once, going twice. All right. Thank you, everyone. So I'll be moving on to question 452. So we have a 32-year-old woman with a history of of IV drug use, and she presents to the emergency department with fatigue and night sweats. Physical examination reveals a temperature of 38.4 degrees centigrade. She has scattered bronchi and wheezes in the lung fields, tachycardia with heart murmurs, and needle tracks on her arms. The chest radiograph reveals several small infiltrates in the left lung field. A transthoracic echocardiogram is obtained, and an apical 4-chamber view highlighting the right-sided chambers is displayed in figure 4.7, which of the following statements about this case is not true. So, sorry everyone, let me look for figure 4.7 for you. Sorry. All right, so this is the echo. This is the right side of the heart. We can see the right ventricle here, and we can see on the tricuspid valve, we can see a mass. So from the history of this patient, we can see that she's an IV drug user. We can see also that there's a mass on her tricuspid valve, and she has fever. So that will give us most likely a diagnosis of right-sided infective endocarditis based on this echo, and is on the atrial side of the tricuspid valve, which is the low volume side, which is where most right-sided vegetations are. So most likely it is infective endocarditis, right-sided infective endocarditis, and with a history also of IV drug use. So the options here are the vegetation displayed occupies the most common endocardial sites of infection in IE drug abusers. This is true. We all know that in right-sided, in IV drug users, the most common form of endocarditis they have is the right-sided form of IE. The left is a lower percentage, but the right is in between 46 to 78%. Then B, sorry. So B, the next option is B. The site of involvement displayed is associated with a higher mortality than other endocardial cells. This is false. This is false. So for C, we know that right-sided endocarditis is not. We have first is mitral valve, then aortic for the right side. So it's not associated with higher mortality than other endocardial sites. So C, the most likely associated organism is Staphylococcus aureus, which is true in IE, as our Chief Kweki presented on Sunday last week. Staph aureus is still the most common cause of IE, although in the right-sided infective endocarditis it's only a cause of 50%. Other causes include gram-negative bacilli and fungus, so that can be common in the right side. So Staphylococcus is still the likely associated organism in this patient. Then D, gram-negative bacilli are a prominent cause of such lesions. This is false. Am I wrong? Gram-negative fungi. I'm not sure of that option. Please, I'll leave the house to help me. But I know that Staphylococcus is the most common cause of IE. Then E, the majority of patients with this presentation are found to have pneumonia or multiple septic emboli on a chest radiograph. This is true. I've actually had a patient like this with right-sided IE that presented, I think her main presentation was even the septic emboli that we thought it was TB. That she presented with septic emboli that led us to find that she had right-sided IE. Please, I'll need help with D, with question 452D. Anyone? Hi. Oh my goodness. Okay. All right. Would anyone like to help with D? 452D.
Thank you, Dr. Precious. Sorry, I was distracted. I've not settled.
That's fine.
Yes. Yes, but I think you are right. You also said that it's only in 50% that will have staph aureus, you understand? And the question is not saying gram-negative is the prominent. It's not saying it's the most prominent. It's just
Okay.
telling us that it's a prominent cause, which is true.
Okay.
They're not saying it's the
It's the
commonest
most.
or it's the least or it's the most. So it's still
I
a
get
true
you.
statement. Yes.
I get you.
Thank
I get you.
you.
Thank
Thank
you.
you.
Thank you
Yeah.
so much.
Yeah.
Thank you. All right. Thank you so much. Any more comments or additions? All right. Thank you, everyone. So we'll move to 453. So a 63-year-old man that has, the question reads as follows: a 63-year-old man has a history of unrepaired patent ductus arteriosus and VSD with long-standing cyanosis. So indirectly, he has Assessemt syndrome. He is admitted to the hospital because of urinary sepsis and IV. Because of urinary sepsis, and IV ciprofloxacin was initiated. Oral tamsulosin, which is an alpha blocker, is begun for prostatic obstruction. His fever resolves, but over the next day, he develops hypotension and worsening cyanosis. Which of the following intervention will be the more appropriate? So the options go as follows: intravenous methylprednisolone and kefepime, that's option A. B, IV dobutamine and oral sildenafil, that's option B. Option C is intravenous phenylephrine and cessation of the tamsulosin, that's option C. And D is IV saline and magnesium. So let's look at the clinical vignette properly first. So we're dealing with a patient that has a history of a PDA and a VSD with long-standing cyanosis. So it has Assessemt syndrome. So what is Assessemt syndrome? This is like an irreversible peripheral, a pulmonary vascular resistance issue that the patient now has moved from a chronic left to right shunt, from a right to left shunt, and the patient and is resulting in cyanosis in this patient. So the patient now has Assessemt syndrome. So what is going on that has worsened the patient's condition? What is the index situation that has happened that has worsened the patient's situation? First, he had sepsis, of which ciprofloxacin was given, and the fever was reduced eventually, but he was given tamsulosin. So tamsulosin is an alpha blocker, and the way it works is that it works by increasing peripheral resistance. So when you look at the calculation for blood pressure, you know, blood pressure is cardiac output times peripheral resistance. So therefore, if you reduce peripheral resistance, therefore you are reducing pressure. And therefore, and if you're reducing the pressure in the left side of the heart, what happens in a patient that has Assessemt syndrome? Indirectly, you are just the patient's condition by increasing that pressure. That means the pressure that is coming from the right side, the patient already has a problem that there's now a right to left shunt. You are now worsening that right to left shunt by now reducing the pressure also in the left side. So, and that also might also lead also to hypotension in this patient. And that's what will now lead to the worsening cyanosis in this patient. So based on our options now that this patient has developed, and patient now also has sepsis, which I think also was a contributing factor to the hypertension and the cyanosis. We all know also that sepsis also causes peripheral vasodilatation. So you're adding an alpha blocker, you're adding on top in a setting also of sepsis. So you are reducing the pressure in the left side for the right side now to now overwhelm the left side. So they are now worsening the cyanosis, and the patient also will now have hypotension. So from all these options here, methylprednisolone and kefepime, I don't see any indication in this patient for that. Dobutamine maybe for the blood pressure, but oral sildenafil for the pulmonary hypertension. I don't know about that option for this patient, but I think the first thing, since it's an emergency and the patient has hypotension, what you would like to do is to increase the blood pressure and stop the precipitant. And the precipitant is that your drug caused it, and you also want to increase the blood pressure. So when I look at one of the options that has both of the things I would do, especially the one that is more acute, is going to be the cessation of the tamsulosin. And you want to start phenylephrine. Phenylephrine, what is phenylephrine? Is an alpha-1 adrenergic receptor agonist, which will help also in bringing up the blood pressure. And how does it do this? Is by improving the peripheral resistance, which was disrupted by the tamsulosin and the sepsis in the first place. So my option would be C. Thank you, anyone. Please, any contributions or additions to this question?
Okay, just to add, sildenafil will actually worsen the hypotension.
All right. Okay. All right. Thank you. Yes, I agree with you. Does anyone else have comments before we move to 454? All right. All right, we move along. Thank you. So 454. We have a 54-year-old man with a history of hypertension and previously unknown and untreated human, that's HIV infection, with worsening shortness of breath. The chest radiograph shows diffuse bilateral infiltrates that are found to represent pneumocystic duodecim pneumonia. An echo is performed to assess left ventricular function and is notable for a small posterior pericardial effusion without cardiac chamber compression. Which one of the following statements regarding pericardial effusion in patients with HIV infection is true? So, A, progression to asymptomatic or cardiac tamponade is likely. B, direct HIV infection of the pericardium is almost exclusively the cause of such effusion. C, the presence of pericardial effusion in HIV patient has no impact on prognosis. D, most effusions of this require glucocorticoid and diuretic therapy for resolution. E, pericardial effusion has become an extremely rare cardiac manifestation of HIV infection in patients treated with highly active retroviral therapy. So let's start from A. So progression, so we're looking for a true statement here. A progression to asymptomatic effusion and or cardiac tamponade is likely. This is highly likely in these patients because in HIV, in a setting of HIV, especially in a patient that is even untreated, pericardial effusion, I know most of us have seen done echoes for a lot of HIV patients. They almost always have at least a bit of pericardial effusion. So symptomatic progression to asymptomatic pericardial effusion and or cardiac is highly unlikely. B, direct HIV infection of the pericardium is almost exclusively the cause of such effusion. So no. So in HIV patients, what exactly is the cause of their pericardial effusion is most likely opportunistic infections and malignancies that will be the cause of their pericardial effusion. The most common is TB. Then you could have malignancies like Kaposi and lymphomas also that can cause their pericardial effusion. So that's not true. So C, the presence of pericardial effusion in HIV has no impact on their prognosis. As I mentioned before, that is not true. That is not true. So most effusions of this type require glucocorticoid therapy for resolution. No, they do not. Because they even said it was a small posterior pericardial effusion without cardiac chamber compression. No. So pericardial effusion has become an extremely rare cardiac manifestation of HIV infection in patients treated with highly active retroviral therapy. That is true. But aside from all the things I've said about, so the true option is E. But aside all things I've said about opportunistic infections and things like that, there are also some other causes of pericardial effusion in HIV patients, especially those that have a low CD4 count. So I read up the capillary syndrome that we were talking about, and they said it's one of the most common cardiac complications in patients with HIV. And the range of manifestation is very wide. It starts from asymptomatic pericardial effusion, which you can see on X-ray, and it can go on to your large pericardial effusion, which can cause a cardiac tamponade, or it can even cause acute acute carditis, chronic pericarditis, which can lead to even constricted pericarditis in those patients. And the pathophysiology behind it is associated with the increase in production of interleukin-2 and TNF-alpha in those patients, especially in those patients that have early AIDS. So the capillary refill syndrome is the capillary refuse syndrome is very common, especially in patients that have low CD4 counts. And that's even what even makes E positive, E true, because that means that with the advent of new and highly active antiretroviral therapy, is rare before we'll see cardiac manifestations of HIV, even this capillary leak syndrome leading to devastating effects like cardiac tamponade and constrictive pericarditis. Thank you, everyone. Please, additions, comments, please.
Good evening, everybody. Please just fire on. If anyone has anything, they can stop you halfway. Thank you.
All right. Thank you. All right. No problem. So question 455. Which of the following statements about the clinical findings in patients with ASD is not correct? For the not correct option. So the first one is a mid-donation murmur, diastolic rumbling murmur at the lower left sternal border are common features on cardiac examination. That's A. B. Patients with ostium primum defect usually show a right ventricular hypertrophy, small r, a small RSR pattern in right pericardial level, pericardial levels and right ward axis on the ECG. I think right was trying to say. Sorry. All right. There's C. Tall waves may signal the development of pulmonary hypertension. D. Cardiographic feature. PSD include right ventricular pulmonary arterial dilation and interventricular septal motion. There is features including cardiomegaly related pulmonary artery. Let's start from A. Let me zoom in my laptop properly. MS. Give me a minute, please. All right. So let's start with A. Which of this is not correct? So A, it's a mid-systolic ejection murmur and a diastolic rumbling murmur at the lower left sternal border are common features on cardiac examination. This is true. So what happens in an ASD is we know that there's a movement of blood from the right atrium from the left atrium to the right atrium. That increases the volume in the right side of the heart. So this volume in the right side of the heart transfers to the right ventricle. So when it transfers to the right ventricle, that's why there's dilation of the right atrium and the right ventricle. This pressure, this increased volume in the right side will present when the blood is trying to go through the pulmonary valve, presents a mid-systolic ejection murmur, which is more of a pressure, a volume overload murmur. So that's where you get your mid-systolic ejection murmur from. And you have a diastolic rumbling. You can hear that in the lower left sternal border, especially if your ASD is big enough. I've never heard it before. There are other clinical things you can find also on an ASD. You can have a loud split P2. You also have a parasternal heave in those patients, especially when they now start having pulmonary hypertension. So A is true. B, patients with ostium primum defects usually show a right ventricular hypertrophy, a small RSR pattern in right pericardial leads, not levels, and right ward axis on the ECG. This is false because this is what is shown. This is what happens in ostium secundum, not primum. So that's our fourth option. Then C, tall R or R prime waves in V1 may signal the development of pulmonary hypertension, which is true. On echo features of ASD include the right ventricular and pulmonary dilatation. I just talked about the right ventricular dilatation and your right pulmonary dilatation, so can also happen. Then you can also have your paradoxical intraventricular septal motion. This is from the increase in pressure on the right side of the heart. And pulmonary hypertension. Then E, radiographic features including cardiomegaly, dilated central pulmonary arteries, and pulmonary pectoral also are things I can find. So our option. So our false option here is B. So I'll be moving on to question 456. So for this question, you have a 54-year-old man who presents with breathlessness on exertion. He has.
Sorry, Dr. Precious.
I'm sorry. Please, I
So
apologize.
that's option B. In case it was twisted, if he has RSR and the left axis deviation, that would be true for the premium type. They have RVH, RBB, but they are actually LED. The
Okay,
premium type. Yeah.
thank you.
Yeah.
Thank you, Chief. All right. Please, do we have any more contributions? All right, I'll continue. So question 4,
Sorry,
5.
Chief General, I didn't get what you said, sir. Sorry.
Sir? Sir,
Chief,
I didn't hear what you said.
Chief General, we didn't hear that comment you just made now.
Oh, Chief, please, can you say your comment again?
Okay, what I said was that if it was the option for that Houston premium, they could have on their ECG, they could have RBB and also RVH, but the axis is actually an LED, as opposed to what you have in the secondum, which is RBB. They also have a right axis deviation. But it was an LED, it would be true for a premium here.
All right, thank you.
All right, thank you. So moving to 256. So the question is as follows: a 54-year-old man presents with breathlessness on exertion. He has been routinely exercising 4 or 5 times a week, but over the past few months, he has noted a decline in exertional capacity. His blood pressure has been consistently less than 130/85 mmHg at his physician's office. An apical 4-chamber view image from his ECG is from an apical 4-chamber view image from his echo is shown. So there's a mistake there. From his echo is shown in figure 4.8. Which of the following statements regarding his condition is true? So this is 4.8 here. All right. So we have an apical 4-chamber view here. We have the rights. We all know where, but we can see that there is, if we compare this part of the lower border of his left ventricle here to the apex around here, we can see that there's marked thickening at this place as opposed to the lower part of the septum and the lower part of just close to the mitral valve here. So we can see that he has something that looks like a localized kind of thickening in his left ventricle. When you mix this type of echo with the clinical finding of the fact that he doesn't have hypertension, right? He has had a history of declining exertional capacity. He doesn't have hypertension, so that's not the reason behind this thickening of his left ventricle or localized thickening of his left ventricle. So we'll be thinking for these patients that most likely he might have a form of hypertrophic cardiomyopathy. So what are the options for this patient? So we're looking for a true option from A to D. This variance represents 10% of hypertrophic cardiomyopathy in Japan. That's A. Then B, tall-peaked precordial T waves are typically present on the ECG. C, a subaortic dynamic pressure gradient is usually present. D, a magnetic resonance imaging will show a spade-like vomiting in the ventricle. There's actually an MRI on this question, boys, in the answers. So when I'm done with the answers, I'll quickly go to the MRI image and show you before we move on quickly. So for option A, so Japan has the highest, so this is false. It actually accounts for 25%. The apical form of HCM accounts for about 25%, so 10% is wrong. So B is tall-peaked precordial T waves are typically present on the ECG. That's wrong. We have your inverted deep T waves that you see in your HCM. Aortic dynamic pressure gradient is usually present, which is false in these patients. Then true. MRI imaging will show a spade-like deformity in the ventricle. Let me quickly go to where the MRI is so that we can talk about it. Give me a second. I don't know why they didn't put it in as part of the. All right. Yes. So the MRI of the patient that I just showed you now. But we can see here, this is diastole and this is a systole. We can see the mark thickening that is around the apex in this patient. We can even see it here also. It's also was around the apex of the heart for the patients. So they described it as a spade-like deformity. I don't know, because I think this looks like a spade. I don't know last time I saw a spade, but yeah. So maybe this looks like a spade. So that's how it was described, like deformity, maybe because of this bulge and this compare. Does
It's
somebody want
more
to say?
for the systolic image. That's where the spade-like appearance.
Yeah. Okay. Chief. Should we say spade? Okay. Yeah. Are we talking about spade like in cards or yeah? Chief Conte. All right. So that's how it works.
From the understanding, the spade is the, I don't know what you call it, the agricultural instruments actually
okay.
that look like a
That's
shovel.
spade. Oh,
Yeah.
okay. All right. Thank you. I wasn't sure. All right. Thank you. So that was the description on the MRI. Thank you. So that's the only true option. However.
And then just to note, in case they tweet the question, in the epic variant type, the dynamic gradient is noted at the mid cavity. That's where you get the tip one where you have asymmetric septal hypertrophy is the one where you get the subaortic dynamic gradient. But for this variant, the apical, it is in the mid LV cavity.
Thank you, sir. Is there any more comments? I'm looking for it. All righty.
Yes, okay. I think another name for the is also called the Yamaguchi syndrome. Okay, that's the Yamaguchi syndrome. When is epicardiotrophic cardiomyopathy, which you just described on the MRI, also called Yamaguchi syndrome. Thank you.
All right, thank you. All right. Do we have any more comments? Question. Thank you, Chiefs. So I think the next question will be 457. So we have a 36-year-old man that presents to the emergency department with shortness of breath. A grade 3 and 4 systolic murmur is auscultated at the apex. The chest radiograph demonstrates pulmonary vascular congestion. Echocardiography in the emergency department confirms the presence of mitral regurgitation and a vicious, okay. Sorry, I can't see both my, excuse me, please, sorry. And a vicious left ventricular contractile function. Which of the following findings would suggest the acute onset of mitral regurgitation? So the options are presence of cardiomegaly on the chest radiograph. That's A. B. Left atrial and ventricular hypertrophy on the ECG. C. The systolic murmur is an spiral to S2. D. A normal jugular venous pressure. So in this patient, the things I would like to highlight here that is going to be very important in the options are going to be that number one, he presented acutely. and he had already a grade 3 to grade 6 systolic murmur, also at presentation acutely, and he also has findings of something that looks like pulmonary edema. So this is most likely going to be an acute event, most likely an acute myocardial regurgitation in this patient. So if it is acute in onset in this patient, I don't expect to see presence of cardiomegaly on the chest X-ray, because that would be pointing to something that has been going on for a long period of time, and there's some form of compensation. So for me, that would be wrong. Then B, left atrial and ventricular hypertrophy on the ECG. That also will be pointed to me of something that the patient already has something like a background heart condition. And most likely, probably the patient already had a pre-existing heart condition prior to this. So, and the patient has already shown maybe some form of compensation prior to presentation. Then a normal jugular venous pressure. In the setting of this acute mitral regurgitation, I don't expect, so you said when the patient has a normal venous pressure, I don't expect the patient to, how do I put this now? The patient will have this, the patient already has pulmonary edema. Let's first go to C. The systolic murmur is short and ends prior to S3. So what happens in an acute mitral regurgitation? So what happens is that there could be a papillary rupture or something that goes wrong with the structures in the heart, and there's an acute MI, acute regurgitation in these patients. So there's going to be backflow of blood from the left ventricle into the left atrium, which is not ready for that amount of pressure. And it just happens suddenly. This is over a period of time, and this is a sudden thing that just happens. So in those hours from that compensation, this patient already has pulmonary hypertension and all of, the patient already has left-sided heart failure. The left atrium will try to compensate and try and push back on this acute regurgitation. And in its bid to push back on this acute regurgitation, the pressure in the left atrium increases. And if the pressure in the left atrium increases, what happens is that MR that you're hearing, instead of to hear it like in the heart failure that we see in DC and all those patients that you hear an MR murmur that is a pansystolic murmur, you hear an MR that is a pansystolic murmur. In this one is shortened before you hear your second heart sound. Because of that, the pushback from the left atrium or the increased pressure in the left atrium trying to compensate for that acute event. So unlike people that have already, or like hearts that have already had MR for a longer period of time, I don't know if I'm making sense in this patient. So that would be, so C would be true. So it would be shortened before. I would like contributions at this point, because that's how I understood it from when I read it. So I don't know if anybody has any additions to that. Then for the normal jugular venous pressure will be false, because this patient already has acute pulmonary edema. So the patient will most likely have a raised jugular venous pressure. So I would like contributions if you understand the pathophysiology, because this is how I understood it. Anyone?
Thank you, Najera. I think your explanation made a lot of sense and very interesting.
All right.
Our only concern is that your projection is so tiny.
Oh my goodness, I'm sorry. Let me tell you what happened, Chief. I can't see the border of the Zoom, right? It's blocking the top of the questions. Let me zoom out. Let me, I apologize, everyone, please. My border of the Zoom is covering the top of my, I think, is this clear, everyone, please? Chief. All right, I'll go to
very well, yes. Thank you.
All right, I'll go to 458 now. I'm going to be talking about the Wegener's curve now. So let's go to this Wegener's curve. I know somebody else must have presented this, but these are flow loops in the heart. So we're looking at pressure in the left ventricle. We're looking at, this is for the left atrium and this for the left ventricle. So I wanted to put a normal one here first before I start explaining this one, but I think somebody else would have explained it thoroughly. But I'm going to go through a normal one and try and explain this one like a normal one. So we all know our A, C, X descents, our V and wide descent. We know that A is atrial contraction, C is bulging of the tricuspid valve, which we rarely see. Then X is pressure, is reduction in pressure in the left atrium. Then you now have your V, which is filling of blood of your left atrium. Then you now have your wide descent, which is pressure or passive filling into the ventricle before you now have another A. So this correlates with your ECG. I wish I had a normal one here because this is very abnormal. So this correlates with your ECG this way here. So you can see your PR, which is atrial depolarization to ventricular depolarization and ventricular repolarization. This is your systole and your left ventricular systole, and this is your left ventricular diastole. So what is going on now in this Wiggers diagram? So you have your ventricular one, and you have in the normal ones, you normally also have your aortic, which is somewhere at the top here. But this one, we only have the left ventricular atrium. So when you look at your A wave here, in an ideal diagram, it's supposed to go this way and stop here before you now see your C. Because here at this point is where there's closure of your tricuspid valve. If you notice, your A wave here is moving, is now big, and is prolonged and slightly prolonged. This shows that there's increased pressure because you know A represents atrial contraction. So for your A wave to be big, it means that there's increased pressure going on in your left atrium. So it has gone, so it's bigger now and it's prolonged. So we now have your X, which is normal. We have your V. Then you now have your Y. Your Y, if you notice here, your Y represents the passive filling of your left ventricle. That's before you now have another A, which is your active filling of the ventricle. If it is this, your Y, it's slightly prolonged. It's not supposed to be this long. It's supposed to come down fully, but it's as if it's taking its time to come down before going to A. So those are the two things that you can find in this diagram that show that something is wrong when it comes to your atrial pressure. When it comes to your atrial pressure, something is going on. So how I can best describe this is that I'm going to be talking about different pathologies now. So for your A to be bigger and for it to be prolonged, we're talking about something that is stopping it from, because that's atrial contraction. That means it's taking a lot more time for it to empty. So that means we're dealing with an obstruction that is going on in your atrium. That's why it's taking so much time, and that's why it is longer. That is what this means. Then for here, for it to be taking also, for your passive filling of the left ventricle, for it to be taking so long, also before it gets to even your A2 that is long, also in diastole, it means that also there's an obstruction prior to your active contraction of your atrium. So we're dealing with an obstruction here, and is an atrial contract, and is an atrial, it's most likely coming from the atrium, because your left ventricle is still going along with what is supposed to happen. So let's go to the options here. We have constrictive pericarditis. What happens when you have, so your options here, like your hemodynamic tracing shows constrictive pericarditis, A, B, mitral stenosis, C, none of the following. So what happens in, let's start with constrictive pericarditis. So there's a lot of pressure in constrictive pericarditis. You know, in constrictive pericarditis, there's increased pressure in between the atrium and the ventricle, because everywhere is tight. That's why they have high diastolic filling pressures. So what happens in that is that for this your wide descent, you're supposed to have passive filling of your atrium into your left ventricle is very sharp. Your wide descent is sharp in constrictive pericarditis, which we cannot see here. So let's talk about mitral stenosis. Mitral stenosis, it makes sense that there's an obstruction in mitral valve that led to the prolongation of your A wave, and led also to the prolongation of your emptying into your, so everything here from diastole before it enters systole is prolonged. So that's as a result of the obstruction in your atrium. That makes sense for mitral stenosis, but let's not stop. Let's go to mitral regurgitation. So what would you find in mitral regurgitation? Actually, in mitral regurgitation, because of that pushback of pressure from your left ventricle into your atrium, this your This your V wave that is here, that is supposed to be when there is feeling pressure at the end of systole, when your atrium is supposed to be, it's going to be big. Your V wave is going to be very big because of that increase in pressure from the regurgitation in your ventricle. So we are going to be seeing a heightened V wave, which we are not seeing here in this. So for restricted cardiomyopathy, it's almost the same thing that you see. You see also a wide descent here. So our best answer here is going to be mitral stenosis. None of the above is obviously false. So please, does anyone have any contribution before I move to 459? All right. Thank you, everyone. So the next question is 45-year-old woman is evaluated by a physician because of a new onset of pleuritic positional left anterior chest pain that radiates to the left trapezius ridge. 3 weeks earlier, she has been evaluated for a viral respiratory tract infection. Cardiac auscultation reveals evanescent scratching sounds in the lower left sternal border with components in both systole and diastole. Which of the following statements about expected findings of this patient's ECG is correct? So for A, we have ST segment elevations with convex upward configuration are likely. That's A. B, PR segment depression may be only ECG, may be the only ECG manifestation. C, reciprocal ST segment depressions are typically present. D, sinus bradycardia is common. E, T-wave inversion develops concurrently with ST elevations. ST elevation. So what does this patient have? This patient obviously has acute pericarditis with obviously a pericardial. So what are the stages of acute carditis? You have stage 1, you have your widespread ST elevation with your PR depression, which happens in about 2 weeks. Then your stage 2 normalization, your ST with flattened ST segment with flattening of your T wave, that takes about 3 weeks. And your stage 3 T waves become inverted, that will take also another 3 weeks. Then before you now have normalization of your ECG, which is about a couple of weeks. So based on what I have said now, A, ST segment elevation with a convex upward configurations are likely. This is wrong. That's why I'm talking about a stem. B, PR segment depression may be the only ECG manifestation, which I have mentioned in the stage 1 of acute pericarditis, which is true. C, reciprocal ST segment depression at present. No, this is wrong. Sinus bradycardia is common, is also false. Then you have T-wave inversions that develop concurrently with ST elevations. I mentioned that your T-wave inversions happen after. That's the stage 3, unlike your ST elevations that are in your stage 1. So your answer here is B. Please, any additions and contributions, please? Before I move on to my last question. All right. Which of the following statements regarding post-myocardial infarction as MI pericarditis is correct? So, all right. So we have 2 types. We have your early and your delayed post-MI pericarditis. So your first option is A, fibrinolytic therapy increases the incidence of early post-MI pericarditis. That's A. B, post-MI pericarditis is more common after non-ST segment elevation MI compared with ST segment elevation MI. That's B. C, when present, clinical pericarditis does not arise until greater than 48 hours after the infarction. D, the use of heparin is associated with increased risk of pericarditis. Sorry, excuse me. The incidence of early post-MI pericarditis is related to infarct size. So let's start with the first one. Fibrinolytic therapy increases. So as I said before, post-MI pericarditis, there are 2 types. You have the early one that can come as early 12 hours post-MI. Then you have the late form of pericarditis, which can happen at about 10 days post 10 days post-MI, which is autoimmune related and is also known as Dressler syndrome. So the early pericarditis is always associated with infarct size, and it is improved by fibrinolytic therapy, anything that can reduce the size of the MI. So the first option is fibrinolytic therapy increases the incidence of post-MI pericarditis, which is false. Because any form of intervention, even if it's your PCI or fibrinolytic, it will reduce the incidence of post-MI pericarditis. Then post-MI pericarditis is more common after non-ST segment elevation MI compared to ST elevation MI. This is false, it's the other way around. It's more common in ST segment elevation MI than it is in non-ST segmentation ST elevation MI. C, when present, clinical pericarditis does not arise until greater than 48 hours after infarction. This is false, can happen as early as 12 hours after. Then D, the use of herpes associated with an increased risk of pericarditis. This is not true. E, the incidence of early post-MI pericarditis is related to infarct size. I've mentioned this before. This is true. Please, contributions, comments from everyone. That's my last question, everyone. Thank you so much for listening to me. Yeah, thank you, Dr. Deojo and Dr. Uzuke. To you, please.
Thank you very much, Dr. Precious, for going through your part in less than an hour, just like 45 minutes. I don't know whether there's further comment or contribution from participants on the platform. Okay, if there are no further comments, we move on to the next presenter. I think we've done for Dr. Precious. You used to be able to share for us.
Sure. You know my issues.
Yes, that's what I'm asking.
You know my issues. No, please. No.
I understand.
Okay.
Thank you. It's kindly on share so that somebody else can share for us. We've done 461 to 505, I suppose. So we continue with Dr. Ike. Dr. Ike, please, are you on the platform? You have 506 to 510. Chief Francis, I will beg you. Can you help us share? Or Chief Olalekun? Thank you.
Sorry, I'm recording. My bandwidth might not support
Okay.
Maybe
Thank you very much. Okay. Thank you so much, Chief Francis. Chief Uzuke, welcome, sir. Please, can you help us share so that we can quickly continue? Thank you, Chief. Or any other person that can help us share, please. Thank you. Five or six, sir. Thank you so much, Chief Uzoke. Dr. Ikechineme, please, are you ready to continue your part? Dr. Chineme. Please, I want to confirm if I can be heard.
We can hear you.
Okay, thank you. I'm not sure if Dr. Chineme is fully here with us, although she's on the platform. Okay. Please, who else is ready? Dr. Huluma, are you ready for your part? Dr. Brown, are you ready to take your part of the question, please? I'll wait for Dr. Chineme. Hello, Chiefs. We have a long way to go, please. Dr. Nwabuze, are you ready to take your part? Dr. Onelom. Wow. Dr. Ibe, you have to finish this book today. I don't know. Okay. So, okay, there, please, can you finish your aspects? I think you have like 5 questions to take. While we wait for others that are warming up to take their parts.
Good evening.
Good evening, ma'am.
I have 6:37 to 6:40. Can you please help me take the question there? Thank you. 6:37. A 67-year-old man with multi-vessel coronary disease is scheduled for coronary artery bypass graft surgery. Which of the following statements regarding CABG and perioperative complications is correct? Coronary artery bypass grafts is a procedure, is a surgical procedure that is done for myocardial infarction patients, and some of its indications include more than 50% stenosis of the left main coronary artery, or when you have more than 70% occlusion of the ladder and left circumflex artery, when you have 3 vessel disease, and number of complications have been associated with it, which could be myocardial dysfunction, cerebrovascular or neurologic complications, acute renal failure, respiratory tract infection, aortic dissection, or even cardiac tamponade. So I'll now go to the options. In-hospital mortality after isolated coronary artery bypass graft has increased over the past 2 decades because of the increased complexity of cases for which the procedure is used. I would say this option is false. Rather, the mortality has increased due to frailty and the clinical characteristics of the patients in which the procedure is being done. Because usually things like syntax and Euroscope scores have been used to pre-op determine the extent and complexity of the coronary artery disease. before the heart team will go ahead to do a CABG for any patient. They will assess with scores like gyroscope and syntax to know the likelihood of mortality and morbidity from the procedure before they go ahead with it. Option B, short-term post-op cognitive decline occurs in less than 10% of patients after CABG surgery. I would say this is false. The sources I checked, I saw a source in Medscape, then also American Journal of Emergency Medicine. They quoted 32% of the people developing cognitive decline peri-CABG, and so less than 10% is what makes this false. It's actually more than that. Then option C, atrial fibrillation appears in up to 40% of patients after CABG surgery. This is true. The figure I got was 5 to 40%. So it can be as high as 40% of patients that will develop atrial fibrillation post-CABG surgery. Then option D, of patients who develop post-op atrial fibrillation, only 20% will spontaneously revert to sinus rhythm within 24 hours. Actually, it's been said that up to 80% of them will revert spontaneously to sinus rhythm within 24 hours. Then the last option, N-acetylcysteine prevents renal dysfunction after coronary artery bypass graft surgery. What I found about renal failure, acute renal failure, is that it occurs in about 4%, and 20% of them will need dialysis. But this N-acetylcysteine preventing renal dysfunction is not true. So the option that is true that I'll be picking will be option C, that says atrial fibrillation appears in up to 40% of patients after CABG surgery. I don't know whether there is any comments, contributions. Okay, question 638. Could you please help me move the question to that aspect? Thank you. A 70-year-old man undergoes coronary artery bypass graft surgery without complication. His first post-op office visit, he reports resolution of his angina symptoms and asks how long the benefit will last. Which of the following statements regarding CABG surgery is true? A, fewer than 2% of saphenous vein grafts become occluded in the early period. This is false. Talking about the different type of grafts that are used, it's been found that saphenous vein grafts, quite a higher percentage of them would become occluded in the early period, and the figure quoted was 8 to 12% actually in the answer, because all the sources I checked didn't really quote it. We just said majority, that most saphenous vein grafts would have that complication of developing occlusion in the period, and the rate at which the development of occlusion occurs increases even up to 1 year, up to 10 years, as compared to the other types. Option B, internal mammary artery graft typically develop intima hyperplasia over time. This is false. They do not develop intima hyperplasia even up to, by the time it's 10 years, you have just more than 80% patency rates. So this option is false. Then C, saphenous vein grafts have a 10-year patency rate of more than 75%. This is false from what I talked about in option A. At 10 years, the patency rate is much more lower, because right from the period, they're already getting occluded. Then option D, radial artery grafts are less likely to develop vasospasm than internal mammary grafts. This is also false. radial artery grafts have the particular complication of having vasospasm as opposed to the internal mammary grafts. Then option E, patients who receive internal mammary artery grafts suffer fewer late deaths and myocardial infarction than those who receive only saphenous vein grafts. This is the true option. So the answer for this is option E. So then just an addition, other arteries are, so the arteries, the source of grafts could be great saphenous vein, which is easier to harvest but lasts less compared to the internal left internal mammary artery, which is more difficult to harvest but lasts longer. Then others we talked about include inferior epigastric artery, then gastric epiploic artery also, then the radial artery. Those are the types that I found when I was checking. So I'll move to question 639 now. A previously healthy 17-year-old high school athlete collapses during a basketball game. Is noted to have brief seizure-like activity and has initial pulse. Prompt bystander cardiopulmonary resuscitation is initiated. An automatic external defibrillator is applied to his chest, indicating a shockable reading. Is defibrillated with immediate return of spontaneous circulation. Which of the following statements is true about sudden cardiac death in young athletes? A. Sudden cardiac death in young athletes is always related to underlying structural heart disease. B. Anomalous origin of the left main coronary artery from the right coronary cause is the most common of the congenital coronary abnormalities that result in sudden cardiac death in young athletes. This option is true. Anomalous origin of the left main coronary artery from the right coronary, it can actually occur either way. You can have the left main coronary coming from the right, or the right coronary artery coming from the left. And from what I checked, it could even be worsened by if the artery is passing between the pulmonary artery, the root of the pulmonary artery and the aortic artery, because that means that there will be even more compression on the artery. And so it is been found that is the most common of the congenital coronary abnormalities that result in sudden cardiac death. And this statement itself makes a false that says that sudden cardiac death in young athletes is always related to an underlying structural heart disease, because this is not a structural heart disease. Option C, normal pre-training history and physical examination exclude the possibility of hypertrophic cardiomyopathy. This is false. A patient having normal findings does not exclude having normal pre-training history does not exclude the diagnosis of an hypertrophic cardiomyopathy, as it's even been found that many of them are diagnosed at the time that the athlete slumps, and then an autopsy is done and then is found to have hypertrophic cardiomyopathy. Option D, patients who experience sudden cardiac death due to hypertrophic cardiomyopathy typically have preceding cardiac symptoms. This is also false. Many could be asymptomatic, and then with exertion, they slump and die. Then option E, congenital aortic stenosis is the most common structural cause of sudden cardiac death in young athletes. This is false. Hypertrophic cardiomyopathy is the most common cause of sudden cardiac death. And so for 639, the correct option is B. Question 640. A 68-year-old woman with a history of hypertension presents to the emergency department with new onset of dyspnea and nausea. The electrocardiogram shows anterolateral ST segment depression, and the initial serum measurement of cardiac troponin is elevated. Which of the following statements is true regarding women who present with acute coronary syndrome? A. Most women present with an acute myocardial infarction, most women presenting with an acute myocardial infarction do not describe chest pain. That is false. I will take false for that. Then option B, women presenting with myocardial infarction are less likely than men to have accompanying cardiovascular comorbidities. Women presenting with myocardial infarction are less likely than men to have accompanying cardiovascular comorbidities. I'll still say false for this option. In option C, women with acute coronary syndrome are more likely to present earlier in the course of symptoms than men. It is false. It's been found that women tend to have atypical symptoms, and they are not likely to present as earlier as men. Then option D, women with ACS are twice as likely to have normal coronary angiogram or non-obstructive coronary artery disease compared with men. This is true. This is what we term the MINOCA, myocardial infarction with non-obstructive coronary artery. It's been found to be more common in women as opposed to men. Then option E, women are admitted to the hospital for the evaluation of chest pain less often than men. I would say false for this. Okay, I saw the comment saying, how sure am I about A? Most women presenting with an acute MI do not describe chest pain. Yes, I was a bit skeptical about this one because looking at it, that they are likely to have angina equivalent kind of presentation and not have chest pain. So I wasn't really sure, but I'm very sure that option D is true. So I don't know. I welcome contributions and assistance on this question.
Hello, good evening. Hello. Hello, am I heard? Hello.
Please go ahead. We can hear you.
Okay, so I think if you go through Braunwald in describing evolution of chest pain, it actually states clearly that three groups of people usually present angina equivalent. One is anxiety, two is women, and then the elderly. So we may have to view that your answer for that A again. Although the other one you said is correct, actually correct. So we have to know the one that is correct and quote out of the two.
Thank you. Sure.
Well, Dr. Sawa also made a comment in the chat box that option A used to be true, but no longer true.
So I think the option A, the adjective is what we should look at. So even though it's true that women with an acute myocardial infarction may not describe chest pain, like rightly said, women, diabetics and all that, they may not present with any pain at all. The trick is, and the caveat is most. It's not most women. So I think that is the focus there. It's not most, because the percentage is not more than 50%. We are looking at around about 30% of the women who present with chest pain. So as far as that is significant compared to men, it's not most of them if you take the proportion of women who present with that. So I think that's why that particular option is false. So it's the most that gives everything out.
Okay, thank you, sir. That's my last question.
Okay. Thank you very much, Dr. Kedara, for taking us through your part. I'd like to ask again if any other person is ready to take their part of the Braunwald book.
I don't know if can we go to the take the later parts too.
Yes, I think we'll have to go there if nobody is ready. I'm even thinking of taking my own part.
So let me, okay, or maybe I take my own too, if you don't mind, while others are warming up.
I think my part is before yours. I don't know. Oh, what's your number, please?
Carry down.
6 something.
I know it's 6 something, like second to the last.
Okay.
Maybe around. Let me check.
Sorry, are you able to record?
Yes, we are recording.
Okay, great. Sorry, I just came in now. I'm trying to catch up.
We understand, sir. Thank you, sir. Okay, apart from Dr. Molade, is any other person ready? Okay, I guess that we've been given a mandate yesterday that we have to finish Braunwald. So I think we'll just, if nobody is ready, we all do it together.
Yes, ma'am. Good evening, ma'am.
Dr. Adedeji. Yes, sir. Good
Yes,
evening.
I can give it a try for my own aspects.
Okay, please, what's your number? I can't remember now.
That's 591.
Okay.
To 600.
Okay. Dr. Uzoke, Chief Uzoke, please, let's go to 591 to 600. Thank you. Dr. Molade, myself, we take our parts and we all work together. We have so much to do. Thank you.
I
591 is up.
Okay, good evening, ma'am and sirs. I'll be presenting my own aspect, starting from 591. But it's a bulk question. This 590 to 593. It said match each hemodynamic scenario with the associated condition. And they give us an option: A, chronic constrictive pericarditis; B, cardiac amyloidosis, which is a form of restrictive cardiomyopathy; C, both, and D is neither. Now, usually, the hemodynamic, the invasive hemodynamic is done to differentiate between chronic pericarditis. I'm still trying to understand the hemodynamics, but I noticed some things that in the hemodynamics, because of there are some terms, because of the restrictions in the wall, there is fibrosis of the pericardium, there is impaired filling. Because of the impaired filling, in the initial phase of the diastolic right ventricular filling, because of the buildup in the right there is deep filling of the right ventricle, and that's why they said they usually have this deep and a rapid early decline at the onset of the diastole. But because of the restriction with the filling, a time comes that there will be a buildup the rise in the end diastolic volume dilated in the early diastolic, and this usually you can see it in anything that causes restriction in fillings on the right. Somebody with restrictive cardiomyopathy, constrictive cardiomyopathy, and cardiac tamponade. And because of that restriction, normally with the pericardial side of the heart, because of that restriction, there's an impairment in that transmission, meaning that prayer is now transmitted through the interventricular septum, and that's what causes the concept of ventricular interdependence, meaning that the right ventricle will be dilating while compromising the left ventricle. And that now this is this that there's a relation between the pressure coming from the interthoracic pressure normally is meant to be transmitted in some aspect of the cardiac structures, but because of that restriction, about association between the interthoracic
Wow. Dr. Adedeji, your network. Sorry, am I the only one that can't hear him clearly?
I was thinking it was my network alone.
I doubt if he can hear us too.
Now on the right ventricle,
Dr. Adedeji, sir, your network is quite unstable, so we are just struggling to hear you, sir. We don't know if you can log out, log back in, or if you have any other network that you can use. Can you hear us, please?
I can hear you, ma.
Oh, your network is better now, but it was really dragging the other time.
Yes, I can hear you, ma.
Okay, we can hear you better now. Thank you.
Yes. These are some of the things that you can actually use to differentiate between the restrictive cardiomyopathy and constrictive cardiomyopathy. In restrictive cardiomyopathy, the left ventricular diastolic pressure, they are usually higher than the right ventricular diastolic pressure in the range of usually more than 5 mm. But converse is the case in somebody that has constrictive cardiomyopathy. Now, another thing that differentiates restrictive cardiomyopathy is that they usually have an elevated pulmonary pressure. They have the pulmonary arterial pressure that is usually high, usually in the range of more than 60. And that, okay, based on this, I think we can attempt, those are the two I can note on this hemodynamics. Now, using this, they said right ventricular pressure tracing shows a deep and rapid early diastole at the onset of diastole with rapid rise of plateau in early diastole, the deep and plateau configuration. Usually you see this in anything that can cause restriction on the right ventricle, constrictive pericarditis, cardiac amyloidosis. And that's why the answer here for 590 is C. For 591, the left ventricular end diastolic pressure exceeds the right ventricular end diastolic pressure. This is usually found in restrictive cardiomyopathy, making B to be the answer. Now, the explanation for this 592, I may not be able to, but let me, the peak arterial systolic pressure, they are usually high They said this is more than 68, with right ventricular diastolic pressure of 15. Usually, this is also seen in restrictive cardiomyopathy. Now, for 592, I guess I read somewhere where they are saying the peak right ventricular systolic pressure, they are usually more than 25. That's for that one usually seen in constricted pericarditis. Those are the littles I can note on that hemodynamics. It's somehow abstract. Contributions as a mass. Hello? Hello? Hello?
Hello, you're audible, sir.
Yes, I don't know if there's any contribution on that aspect. Or I can continue. Hello, I can go ahead.
Hello, I'm trying to check if Prof is there to see if we can actually. Good evening, Prof. Sir. Hello, Prof. Sir. Good evening, sir. Maybe Prof is busy. You can go ahead. We will note it down during our classes.
Okay.
Yeah.
Okay. The next one is match the following description with the appropriate symptoms in aortic stenosis. The A is palpitation, B is angina, C is syncope, exertional dyspnea as a manifestation of heart failure. Now, in the natural history of aortic stenosis, has been studied. We realized that in patients presenting with certain symptoms, they've observed that over time, this is their expected life expectancy. They have a survival rate. In patients that has angina, they realize that they have a lifespan or the survival rate of 3 to 5 years. In people coming with syncope, usually that one is 2 to 3 years. While heart failure has the worst survival rate of 1 to 2 years. Adverse survival in patients with aortic stenosis. To answer this question, they said most significant marker for adverse outcome in aortic stenosis predictive of a 1 to 2 year survival if the valve is not repaired. As I said, if the valve is not repaired, it will 1 to 2 years, making the answer for this 594 to be D. Now, 595 associated with reduced survival in an untreated aortic stenosis of 3 to 5 years. This is observed in patients with angina only. That means the answer is B. (596) associated with reduced survival in an untreated aortic stenosis of 2 to 3 years, usually seen in patients with syncope. The answer for 596 will be C. Not a marker of reduced survival in patients with aortic stenosis. That's palpitation. Is not a marker of survival in patients with aortic stenosis. I don't know if there is any contribution, or I should go ahead. Hello? I can go ahead?
Yes, please.
Okay. 598 to 601. They said for each type of procedure below, match the appropriate prophylactic regimen. The options are A, no antibiotic prophylaxis is required. B is amoxicillin. Those are the options. C is clindamycin, and D is amoxicillin. Now, the first question is 598 elective colonoscopy in a patient with a mechanical mitral valve. Now, usually high-risk patients are patients that has prosthetic heart valves or prosthetic materials that are used to repair the valves, patient with prior endocarditis, patient that has unrepaired cyanotic heart disease, patient that has repaired congenital lesions with residual deficits, or patient that has a repair done in the last 6 months, or a patient with cardiac transplants with valvulopathy. Those are the high-risk patients that usually we consider giving them prophylaxis for infective endocarditis when you are doing the dental procedure. And usually what they use is the amoxicillin. And those are resistant or have side effects of amoxicillin to talk about the use of clindamycin. Now, having said that, I will now go to the question. They said elective colonoscopy in a patient with mechanical mitral valves. This is a non-dental procedure. Despite the fact that the patient has a mechanical valve, it's not an indication for the use of prophylactic antibiotics. Now, for 598, the answer here is likely to be A. No antibiotic prophylaxis is required. Now, for 599, dental extraction in a patient with bowel prosthetic aortic valve. Now, looking at that option, amoxicillin, which is the first line drug they use for preventive prophylaxis in infective endocarditis. Now, the answer here is B. Amoxicillin 2 grams orally to be taken 30 to 60 milligrams before the procedure. That's for 599. For 600, dental extraction in penicillin allergy patients with a mechanical aortic valve. As I said earlier, in a patient that are allergic to penicillin, usually we consider the use of clindamycin, and that makes the 600 to be C. Now, since the bulk question, the last question is elective esophagogastroduodenoscopy in a patient with mitral stenosis. This is a non-dental procedure, meaning that the use of prophylactic antibiotics for infective endocarditis is not indicated. Now, for that 601 rather, the answer to be A. No antibiotic prophylaxis is required. And that marked the aspect of my own. Thanks for listening.
Thank you very much, Dr. Adedeji, for taking your aspect of the Braunwald book.
Yes.
Dr. Chineme was saying that she was ready. Dr. Chineme, are you now with us?
Yes, ma'am. Good evening.
Good evening. You're welcome, ma. Is it possible that you just finish up with your aspect so that we know what's left?
Yes.
Thank you.
Okay. Just a minute.
What's your number, please?
She's 506 to 510, I think. She started yesterday.
Okay, question 506. Okay, good evening all. Okay, so we'll be looking at question 506. I can't see anything. So please, can you go up a bit? Okay. Okay, so the question says, which of the following statements regarding the natural history of idiopathic pulmonary arterial hypertension is true? So a quick one, just to remind us about pulmonary arterial hypertension. So basically, pulmonary arterial hypertension is divided into 5 types. And then the first type, which is a pulmonary arterial hypertension, that's group 1, is divided into 7 subtypes. So the 7 subtypes, the type 1, we have patients that have idiopathic pulmonary arterial hypertension. Then we also have patients that have genetic causes where the BMPR2 is actually implicated. We have from toxins, from drugs, that's the 3rd subtype. And then we have from also diseases associated with pulmonary arterial hypertension, like HIV, schistosomiasis, connective tissue disease, portal hypertension. And then we have veno-occlusive disease. That's the 5th subtype, veno-occlusive disease of the pulmonary artery or capillary hemangiomatosis. Then finally, we have persistent hypertension of the newborn. Okay, so that's the 7 subtypes under the pulmonary arterial hypertension. Then group 2, as we know, are causes from left-sided causes. So if we have patients with heart failure, valvular heart diseases, cardiomyopathies, all of them fall into the group 2. Then group 3 are actually from lung diseases. So if a patient has COPD, has interstitial lung disease, has obstructive sleep apnea, or anything that actually affects the right side, the patient will be under stage 3. And then for stage 4 is the chronic thromboembolic pulmonary hypertension. Usually from a chronic pulmonary embolism, they graduate to CTEP. And then finally, group 5, which is miscellaneous, is from different causes that really can be grouped into any of those groups, like the myeloproliferative diseases, Langerhans cell, histiocytosis, neurofibromatosis, and all of those. So they are under group 5. So referring to idiopathic pulmonary arterial hypertension, we're referring to one of the members of the group 1. Okay, and basically idiopathic pulmonary hypertension means that you have a pulmonary systolic artery pressure of greater than 25 mmHg when you're resting, and also you have a pulmonary capillary wedge pressure less than 3, and then finally you have a pulmonary vascular resistance of greater than 3 Wood units. You classify to be said you have idiopathic pulmonary hypertension. So basically in these patients, the cause of the hypertension is not known. And most times in these patients, although recently it's been found that they have some familial links with the BMPR2. So in these patients, most times pathophysiology, the cause is really not known, but there's an insult to the pulmonary arteries that results in endothelial scarring, proliferation of the intima, and then generally proliferation of the cells. And finally, they can have arteriopathy that leads to fibrosis of the pulmonary artery. So the pulmonary pressures go up. There might be right ventricular dilatations. The pressures can be transmitted to the right atrium with maybe tricuspid regurgitations, and finally to the right side of the heart generally can fail. So the patient can have, commonly they have dyspnea. So they come with features of dyspnea. They can have cyanosis. They can have elevated jugular venous pressure, peripheral edema, as we all know. So it's been noted that it's common in younger people, especially in women. Women about some books say 2 to 9 is to 1, and then some say about 2 to 4 is to 1, but it's more in females than males, and more in the younger ages, although it can occur in the 5th to 6th decade of life. So for this patient, the symptoms, the signs they usually have, of course, you will have a loud P2 because of the pulmonary hypertension, which is the commonest cardiovascular sign they have. You can also have left parasternal heave from the right ventricular hypertrophy, maybe an S3, right S3 sounds. You can have the murmurs of tricuspid regurgitations, and generally features of right-sided heart failure, heart disease. So for them, the gold standard for diagnosing this condition is to do a cardiac catheterization. But we can also use other measures to diagnose it because of the invasiveness of that procedure. And then basically the treatment for this patient is to make use of vasodilators. So previously it was only calcium channel blockers that were being used. And before they are being used, we actually have to make sure that the patient is not in right-sided heart failure. And then basically the cardiac index is not less than 2 before making use of it. And they also do a vasodilatory test where the patient is given inhalational vasodilators. And then the test actually is positive if your mean pulmonary arterial pressure drops by 10, or if you have very high pressures, it goes below 40, then they say the test is positive. And so when you have patients that have this positive test, they are going to benefit from calcium channel blockers. So then other medications we can use are the newer agents, like the prostacyclin analogs, like the epoprostanol, treprostinil. Then we can use the endothelin receptor antagonist, that's the bosentan and brisetan, and then the macitentan. Then also the 5-phosphodiesterases inhibitors, sildenafil. We can use the guanylate cyclates. I think that's the most recent, the guanylate cyclate stimulators. That's the riociguat, can also be used. Then the FDA 2015, the first line of treatment is brisetan and tadalafil, because it's been found in the ambition study to reduce the disease progression and increase the exercise ability for the patient. Patient may also benefit from anticoagulation, may benefit from diuretics in the treatment of the right-sided heart failure. And finally, surgery can be done if medical therapies aren't working out. So the patient can have a lung transplant, single or double lung transplants can be done for the patient, and then the patient can have an atrial septostomy, like in the interim before the actual lung surgery can be done for this patient. So in answering the question, the prevalence is equal in males and females. Like I've said, it's more in females than males. Some people say 2 to 9 is to 1. Some people say 2 to 4 is to 1. But it's more in females than males, so it's not an equal prevalence. Then chest pain related to right ventricular ischemia is the most common manifesting symptom. So for them, the most common manifesting symptom is dyspnea as a result of the pulmonary hypertension, pulmonary edema. So the patient is usually dyspneic. And so that's the first first symptom. Then sudden cardiac death is a potential complication, but only in patients with class 4 symptoms. So this is also, most times for them, the death is usually from a right-sided heart failure. And then in about a few percentage, about 26%, they can come down with sudden cardiac death, usually in patients with class 4 symptoms. So that option is true. And then increased intensity of S1 is the most common physical finding. So increased intensity of S1 is the most common physical finding. That's false S1 is closure of the AV and the AV valves. So here the most common sign is a rise in the increase in the P2, which signifies the pulmonary hypertension. Then echocardiographic evidence of right ventricular hypertrophy is present in a minority of patients. So for patients with idiopathic pulmonary hypertension, echocardiography evidence of right ventricular hypertrophy occurs in majority. So minority makes this option false. So having said that, question 506, the answer is C. Thank you. Do we have any question, contributions?
Okay.
Thank you very much.
Hello.
Hello, good evening, sir.
Okay. Probably I didn't get you very well. Can you recap those your diagnostic values for pulmonary hypertension?
Hello?
Hello?
Yes, I can hear you now. Good evening.
I didn't get it. Can you please recap those pulmonary arterial
Recap what? The
values?
treatment? I didn't hear you, sir.
No, not treatment, the values.
Okay. So we said patients with pulmonary arterial hypertension. For you to make a diagnosis of that, you have a resting mean pulmonary arterial pressure greater than 25 mmHg. That's at rest, your mean pulmonary arterial pressure is more than 25. Then your pulmonary capillary wedge pressure is less than 15 millimeters of mercury. And then your pulmonary vascular resistance is greater than 3 Wood units.
Okay, thank you very much.
Okay, sir. Okay.
Hello?
I don't know if we have any other question. Go ahead, sir. Good evening. Yes, I can, sir.
Okay. The old values for that.
Chief Sawa, I don't know. Are you using any earpiece? We can't really hear you clearly.
Okay.
Sorry, I can't hear you clearly.
Let me just type what I want to say.
But we can hear you now.
Okay, can you hear me now?
It's better now, sir.
Okay, fine. I said those values are actually old values. If you look at the most recent guidelines for pulmonary arterial, the values are much lower. The pulmonary pressure has been lowered from 25 to 20, while the pulmonary vascular resistance is 2 Wood units. I thought it's important for us to take note of that.
Okay, sir. Thank you.
Dr. Chineme, and thank you, Chief Sarah, for that contribution. In addition, these revisions, I think they were made last year or 2022, are evidence-based. So the earlier cutoff of 25 was kind of sort of arbitrary. But after years of treating patients with mild pulmonary hypertension and different stages, it was realized that once the MPAP gets to 20 above, starts to rise in that direction, then outcomes kind of start to decline. So the thresholds were lowered so that patients can be diagnosed early enough that interventions can be put in place to retard that progression and improve outcomes rather than probably starting treatment later and then the response wouldn't be too great. Thank you.
Thank you so much, ma.
Thank you very much, ma. Chief Sawa, could you please still write that thing down on the blog, because a good part of that your comment was actually faith and blood. Thank you.
What I'll do, I think I made a presentation in our unit as a kind of a summary of that updated guideline. I'll try to find the slides and send it on the WhatsApp group.
Oh, well, I appreciate that.
Chief Adeyanju has also typed it in the chat box. Thank you very much.
Oh, thank you.
Thank you.
Okay, so question 507. They said, which of the following statements is true about the heart valve abnormality shown in figure 4.25? I don't know if you can go to figure 4.25.
Can you see the valve?
Yes, I can. Thank you, sir. So looking at the valve, we can notice that this is the aortic valve because it has 3 cups. We can also notice that the valve looks thickened, it looks sclerosed and calcified. Okay, so this would go for aortic stenosis from calcification, the type that is usually common in elderly people. So it says, can we go back to the question? Let's see the question. Okay. Okay, thank you. So 507, so which of the following statements is true about the heart valve that we've just seen? So the abnormality is most likely congenital. So because we are actually seeing 3 cups, if it's a congenital abnormality, we may have a bicuspid aortic valve, which would have 2 cups. So this is false. Then endocarditis frequently leads to this abnormality. This is obviously false. Diabetes mellitus and hypercholesterolemia are risk factors for its development. So this is true. And then a loud diastolic blowing murmur is likely. So this is also false, because in patients that have aortic stenosis, they usually have a crescendo decrescendo systolic murmur that is heard around the upper part of the chest wall, that's the second intercostal space, the right sternal border. So that actually makes this option false. So the correct option is option C. DM and hypercholesterolemia are risk factors for its development. So I think this is straightforward. We can go to question 508. So question 508, which of the following statements about hemodynamic findings in constrictive pericarditis and restrictive cardiomyopathy is correct? So I think somebody else has said something about constrictive pericarditis and restrictive cardiomyopathy already, but just to add to that, constrictive pericarditis, basically, there is a problem with the pericardium that makes it unable to expand, it loses its elasticity. And then for restrictive cardiomyopathy, basically there's a problem with the myocardium itself, but the pericardium is intact, the pericardium is okay. So some of the differences in this can be related to the differences in their hemodynamic, their filling pressures, their systolic pressures, and all of that. So in differentiating them, I just want to list some of the differences. For the constrictive pericarditis, what happens is that there is actually a difference between the intrathoracic pressure and the intracardiac pressure. So usually in the phases of respiration, like in inspiration, we expect the intrathoracic pressure to drop. As the intrathoracic pressure drops, there's also venous filling during that phase. So that should be transmitted down to the intracardiac pressures. When in patients with constrictive pericarditis, you find out that the intrathoracic pressures are not transmitted to the intracardiac pressures because of the pericardium that closes it in. So what happens is that you have, when there is a drop in the intrathoracic pressure, there is no drop in the intracardiac pressure. So the intracardiac pressures are elevated when there is a drop in the intrathoracic pressure. So that leads to an increase in the filling of the right side of the heart. And at that same time, there's a reduction in the filling of the left side of the heart. So when there's a filling of the right side of the heart, what comes into play is the ventricular interdependence. So the ventricular interdependence just means that there is, based on the fact that the right ventricle is being filled and extended, it actually inhibits the filling and extension of the left ventricle. So in these patients with constrictive pericarditis, the ventricular interdependence is increased, unlike when we have patients with restrictive cardiomyopathy. So basically in restrictive cardiomyopathy, when during the respiratory phases, especially the inspiration, when there's a drop in the intrathoracic pressure, is also related to the intracardiac pressure. So there's also a drop in the intercardiac pressure. So for them, the ventricular interdependence doesn't really it doesn't come there. It doesn't play its part there. So in differentiating them in constrictive pericarditis, the intrathoracic pressures are not transmitted to the intracardiac pressures, but in patients with restrictive cardiomyopathy, the intrathoracic pressures are translated or transferred to the intracardiac pressures. I don't know, sorry, my voice is hoarse, I think because it's night and I feel like sleeping. Okay, then also the ventricular interdependence is more in patients with constrictive pericarditis. Like I've said, during inspiration, as there's a drop in the intrathoracic pressures, there's an increase in the intra-abdominal pressures that lead to increased filling. And that's why they have the proximal spine. And then when there's an increase in the filling, so the right ventricle is enlarged and that pushes on the left ventricle and prevents it from filling at that particular time. So there's more ventricular interdependence coming to play in patients with constrictive pericarditis, unlike in restrictive cardiomyopathy, where the pressures in the intrathoracic are translated to the pressures in the intracardiac region. So there's a fall in both pressures. So they don't have the ventricular interdependence. And also of note is that when we are now looking at the hemodynamics of the right ventricular diastolic and diastolic pressures and also the right ventricular systolic pressures. So in patients that have constrictive pericarditis, it's important to note that the filling, that's the diastolic filling, is dependent on the volume and not the distension of the chambers, because basically there's really no spurious distension of the chambers because they are emboxed in the pericardium that is thickened. So in them, they usually have the filling, the diastolic filling, dependent on the volume, not the extensibility or elasticity of the ventricle. Unlike in patients with restrictive cardiomyopathy, where it is not dependent on the volume, but also on the ability of the chambers to at least dilate a bit to get that feeling. So that's what gives the hallmark of constrictive pericarditis, where you have equalization of the pressures in the four chambers, because at all times the pressure is dependent on the volume. So, and the volume is the same all through the chambers. Unlike if you have, because the chambers are not really like dilating. So usually what happens is that as you start an early diastolic filling, it dilates. When it gets to where the elasticity of the pericardium is, there's a sudden abrupt stop. So in this patient, you have something like a deepening going, and then finally it plateaus. So that's what gives the dip and plateau. That's the square root sign. But the square root sign can be seen in both of them. Although some places say the square root sign can be seen in both of them. That one needs clarification. But the square root sign can be seen in constrictive pericarditis. Then also in differentiating them, we also find out that if you do the right ventricular systolic pressure, the ratio of the right ventricular systolic pressure to the right ventricular diastolic pressure in constrictive pericarditis is usually less than 3 millimeters of mercury. But in restrictive cardiomyopathy, it's usually greater than 3 millimeters of mercury. Now, if you're looking at the pulmonary arterial systolic pressure, it's more in restrictive cardiomyopathy. Usually some people say greater than 60 than it is in constrictive pericarditis. And then if you're looking at the right ventricle, left ventricle discordance, there's a discordance in constrictive pericarditis because it has more interventricular dependence, okay? So there's a discordance here, but there's a concordance in patients with restrictive cardiomyopathy. And if you're also looking at the BNP levels are normal in constrictive pericarditis. They are elevated in patients with restrictive cardiomyopathy. And then concerning the end diastolic pressures, the end diastolic pressures are equal in constrictive pericarditis, and in restrictive cardiomyopathy, the left ventricular end diastolic pressures are more than the right side. So that makes it also discordant. Okay, so that's just the addition to some of the differences. It's important to actually know them. So going to the question itself. Okay, so question A, a diastolic dip and plateau pattern is present in the right ventricular waveforms in constrictive. Sorry, sir, you've gone out. Okay. Okay, thank you. So a diastolic dip and plateau pattern. Yes, sir, it's okay. A diastolic dip and plateau pattern is present in the right ventricular waveforms in constrictive pericarditis, but not restrictive cardiomyopathy. So we are looking for the option, we're actually looking for the option that is true. So please, can you go back to the question side? Let me see what we are looking for. Okay, so we're looking for the true. So I can't, okay, so we're looking for the true, which of the following statements about hemodynamic findings in constrictive pericarditis and restrictive cardiomyopathy is correct? So we can go back, thank you. Please come down a bit. Okay, thank you. So a diastolic dip and plateau pattern is present in the right ventricle waveforms in constrictive pericarditis, but not restrictive cardiomyopathy. So we say basically the dip and plateau, anything that causes problems with the right side, feeling of the right side can give it. So both the constrictive pericarditis and restrictive pericarditis has the dip and plateau pattern. Okay, then so that option is not the true option. Then question B, concordance of left ventricle and right ventricular systolic pressures during respiration is typical of constrictive pericarditis. So we've said there is a discordance in constrictive pericarditis and a concordance in restrictive cardiomyopathy. So that option is also false, not true. Now, in constrictive pericarditis, the ratio of the right ventricular systolic pressure to the right ventricular end diastolic pressure is usually greater than 3:1. So the pressure difference in constrictive pericarditis is usually, the pressure difference is more than, so usually some people say it's more than 5 millimeters of mercury. So that should be like 5:1. So this is also false. Then an RV systolic pressure greater than 50 is more consistent with restrictive cardiomyopathy than with constrictive pericarditis. This is true. Restrictive cardiomyopathy, the RVSP is usually more than 50. The pulmonary arterial systolic pressure is usually greater to more than 60. So that's in keeping with restrictive cardiomyopathy. So the true statement is option D, but this question is open to real comments and questions. Thank you. Okay, I'm assuming there's no contribution or question. Okay, so question 509, Riociguat is an approved medication that results in improved exercise tolerance in patients with pulmonary arterial hypertension or chronic thromboembolic pulmonary hypertension. The mechanism of action of Riociguat is. So Riociguat, like we say, is a guanylate cyclase stimulator. Basically, there are 3 conditions you can use Riociguat. One in pulmonary arterial hypertension. Someone wants to say something?
Go ahead, please.
Okay. So you can use them in pulmonary arterial hypertension. That's group 1 pulmonary arterial hypertension. Then they can also be used in patients that have chronic thromboembolic pulmonary hypertension. They can also be used in patients that cannot undergo surgical procedures but have CTEP. And even after the surgical procedure, which is the pulmonary thromboendarterectomy, which is the gold standard for treatment for CTEP. So even in patients after that procedure that do not get better or still have symptoms after the procedure, ryosigwat can also be used. So it's been found to improve their exercise capacity and also impede the progression of the disease. So another important thing about this is that ryosigwat works through guanylate cyclase. So, and we know it converts guanosine triphosphate to guanosine guanosine monophosphate that helps in vasodilation. So this is also done by nitric oxide, but it doesn't work through nitric oxide. Like, it doesn't increase nitric oxide to do that. It directly stimulates guanylate cyclase for vasodilatation. It's also important to note that it's given in adults, okay? And usually you start at 0.5 milligrams and then you increase 2 weekly or 2 weekly to 4 weekly, depending on the patient's response. And it's given 3 times a day. And I think the maximum dose is about 5 milligrams. And then for ryosigwat, it's not used in children. Okay. And then also it's not used in pregnancy and breastfeeding. It's not been, I don't think there's any study that's shown it can be used there. So it's avoided in those patients. And then it doesn't really have any reactions with warfarin. So it can be used with warfarin. But when you're using other substances like dipyridamole, other drugs like the dipyridamole, if you're using patients with theophylline, you should also be careful. It has some drug-drug interactions with them. And then if you're using enzyme inhibitors, like the erythromycin, they will increase the levels of ryosigwat. And so you will need to watch out for that. Then also in patients taking ryosigwat and taking antacids, there should be a time lag between them because antacids actually chelates ryosigwat. And then the blood pressure, ryosigwat leads to a drop in the blood pressures. So we don't advise it to be used with the phosphodiesterase inhibitors because it will further reduce the blood pressures. So that also should be watched out for. So answering the question, nitric oxide donor, so that's false. Soluble guanylyl cyclase stimulator, that's true. Heme oxygenase 1 inhibitor, that's false. KIV1 5-channel stabilizer, that's also false. So the correct answer is option B. So for 510, so a 54-year-old man presents to his physician with a 1-week history of dyspnea on exertion. He has cough and pleuritic chest pain. Okay, thank you, sir. Other examples. Okay, thank you. Okay, so a 54-year-old man presents to his physician with a 1-week history of dyspnea and exertion, cough, pleuritic chest pain. His examination is notable for an elevated JVP, distant heart sounds, and mild bilateral lower extremity edema. The chest radiograph reveals an enlarged cardiac silhouette. Echocardiography demonstrates a large circumferential pericardial effusion, and echocardiography guided pericardiocentesis is performed, removing most of the fluid. So cytologic evaluation reveals adenocarcinoma, which one of the following statements is not correct. So basically the patient has a malignant pericardial effusion with features of like pericardial tamponade, the distant heart sounds, the elevated jugular venous pressures that the patient has, and then the diagnosis already shows that the patient has adenocarcinoma. So for patients that have malignant pericardial effusions, there are certain tumors that have been implicated in them. So the commonest is the lungs, like the spread from the lungs to the pericardium. We can also have the breast, lymphomas can also spread to the pericardium. And then for the malignant pericardial effusion, it can actually be from a direct spread or maybe a hematologic spread or from a lymphatic spread. And in these patients that have the malignant pericardial effusion, the prognosis is poor. It's also been shown that even when you pass a drain, take out like pericardiocentesis, take out the fluids, they reaccumulate again and very fast. So echo should be repeated for the patient in like 72 hours to actually check if there's reaccumulation and to ensure that the patient is not tamponading. Okay. And now if the fluid reaccumulates rapidly, and you can repeat the pericardiocentesis, but you can also do the use of sclerosing agent, okay, like the tetracyclines, to take care of that. Then for the surgical procedures, like the pericardiectomy that can be done for these patients, is usually reserved for when the patient is stable because it has very high mortality. So you can either do your pericardiocentesis, watch the patient, or you can do the sclerosing therapy, or you can do like a limited procedure, like doing subxiphoid pericardiostomy, where you just open a pericardial window and then take care of it via video-assisted thoracoscopic pericardiectomy. So this can be, these are actually how malignant pericardial effusions can be managed. So going to the question, the most likely primary malignancy. So which of the, we are looking for the option that is not correct. So the most likely primary malignancy in these patients is the lung. So yes, that's the commonest site of spread. So it's a correct option. So the prognosis is poor despite aggressive surgery or chemotherapy. Okay, so basically like what we've said in our patients, it's true that the prognosis is poor, actually, despite what you do. Okay, then pericardial sclerotherapy will not significantly improve the long-term prognosis. So what pericardial sclerotherapy actually won't improve long-term prognosis for this patient. So this is actually a true statement. Total surgical pericardiectomy should be performed urgently. So this procedure has high mortality, shouldn't be done in a patient that is unstable. So this is actually false. You should go for something more limiting, like either you're doing a pericardiocentesis or sclerotherapy, or you do the video-assisted type of pericardiostomy, but this total surgical pericardiectomy should be reserved for when the patient is okay, and it usually has high mortality. So if there are other things you can do, it's preferable. Then finally, echocardiography should be repeated within 72 hours. That's a true statement, to be able to rule out tamponading and to see generally the effects of the pericardial effusion. So the wrong option is option D, total surgical pericardiectomy should be performed urgently. So that's false. Thank you.
Thank you very much, Dr. Chineme, for your excellent presentation. Despite the fact that you were feeling sleepy and you also had some houseness. Thank you so much. Well, I'm not sure that any other person is ready, but Dr. Ozuke, please let me take my part. Can you go to 671? Because we can't just stop here. We have a lot to do. I think Dr. Malade is also ready, so go to 671. While people are still warming up for their part, because we have to finish Braunwald tonight. That was our agreement yesterday.
Yes.
Thank you.
Well, I think about 671 is my own to present. What do you think?
Oh, is it yours? I thought it was mine. Are you ready? I should just take it.
Can present it, or you go ahead and present.
Okay, we can all do it together then. But let's just start.
Yeah.
Thank you so much, Chief. It's okay. Good evening once again, everyone. Luckily, these are blog questions, so we should be able to move fast. Please, I will plead for contributions from the whole class so that we can do it together. So it reads question 671. For each description listed below, match the appropriate diagnosis. A. Behçet syndrome. B. Systemic sclerosis. C. Ankylosing spondylitis. D. Giant cell arteritis. Then the 671 option is granulomatous formation in the coronary arteries. 672 myocardial fibrosis and contraction band necrosis. 673 histologically similar to syphilitic aortitis, and 674 occlusion of the subclavian artery and aneurysm of the common carotid artery. So I'll just take us through each of the syndrome one by one. Looking at Behçet syndrome, the common things with Behçet, I think they talked about it first being described by a Turkish physician in the early 90s. And then what we see with them is that they have aphthous ulcer. Apart from that, they can have genital ulcer and uveitis. The uveitis that they have can either be anterior or posterior. I think they have more of anterior than posterior. Apart from that, they can also have vascular involvement in which they both affect both the venous and the arterial system, and they can form thromboembolism in the vessels. So they have vascularity that is affecting those systems, can affect either the small artery, the large artery in Behçet syndrome. They can also have other systemic manifestations. They can affect the gastrointestinal system, the CNS, where they have hallucination, and also some arterial thromboembolism in the CNS. What else about Behçet? Okay, I think that is just a brief overview that I can remember about the Behçet syndrome. Then going to systemic sclerosis, we have limited and systemic sclerosis. So the systemic sclerosis, there is thickening of the of the skin, in which affects the faces and can also affect some internal organs. There is fibrosis or fibrous band around affected organs. And I think they've talked about SCL70 being positive in them. It can also coexist with other autoimmune diseases or connective tissue diseases. That's what I can remember about that. Then looking at ankylosing spondylitis, these are part of the spondyloarthropathies that we commonly have. And okay, I'll come back to ankylosing spondylitis. Then giant cell arteritis is also called temporal arteritis. And in this, what they have mostly is granulomatous formation in the affected large arteries. And patient can come with maybe with sudden blindness. Then they can have, but while they're combing their ears, I think they can also have severe headache in them. They can also have jaw claudication, and it's due to inflammation of the large vessels. What else is in giant cell arteritis? I think steroids has been said to be used for the treatment in giant cell arteritis. It occurs commonly in males greater than 50 years of age. And I think sometimes in a little percentage, I think 25%, they have a coexistence with polymyalgia rheumatica in them. Okay, so trying to attempt the question. So for 671, granulomatous formation in the coronary arteries. For this, I will be thinking that the correct option here is D, because in giant cell arteritis, apart from affecting the temporal arteries, they can also affect other arteries. And they said that after affecting the temporal arteries, the next set of arteries that they can affect are the coronary arteries. Then I think it's males. I think giant cell arteritis is in males. I don't know, but I stand to be corrected, sure. I stand to be corrected. So for 671, I would think that the correct option is D. For 672, myocardial fibrosis and contraction band necrosis. For this, I'm thinking that the correct option is the systemic sclerosis, in which we can also find myocardial fibrosis in them. Then 673 is histologically similar to syphilitic hepatitis. This, I was thinking that 673, maybe the correct option there will be C. No, yes, C. I will be going for C there. And for 674, I will think more of option A for 674. Please comment and contribution are welcome. Somebody is talking about GCA. Sorry, comments and contributions, says Amaz.
Andrew, that is correct. You can move on. If anybody is contributing, they can add as you are moving. Thank you.
Okay, they're saying that giant cell arteritis is more common in females. That's what is being said.
Yeah, so just like many of the, I mean, it's not a connective tissue disease, but just like many autoimmune, like the polymyalgia rheumatica, it's more common in females. Lifetime risk is said to be about 1% in females and 0.5% in males. And many a times the scenarios being given will be a middle-aged elderly woman coming with headache, blah, blah, blurring of vision, that sort of thing.
Okay, thank you very much for that. Thank you. Okay, so I will move on to the next set of questions. 675 to 678. Match the cardiac medication with the potential adverse effect. A, heparin, B, alpha-methyl-dopa, C, procainamide, D, ticagrelor. And then for heparin, I can remember that commonly we have heparin-induced thrombocytopenia. For alpha-methyl-dopa, I can remember that we used to have a positive direct comb test for alpha-methyl-dopa. Procainamide is usually associated with rash for procainamide, and ticagrelor, that's a PY2 inhibitor and is used during PCI, and I think that it has a risk of bleeding and also dyspnea. So looking at 675, erythematous rash, leukopenia, I'll be thinking option C for that. 676, I'll be thinking of alpha-methyl-dopa for that option. 677, I will leave that one for now. 678, that will be heparin. That will be option A, heparin-induced thrombocytopenia. We've had patients that actually had that during that we had on admission. Then for 677, yes, that will be ticagrelor. That will be option D. They usually have bleeding and dyspnea. Thank you very much. I welcome question and comments and additional clarifications.
Thank you, Ade Andrew. Be moving on then. Anybody who has questions can always ask. Our contribution to make can always put forward that. Thank you.
Okay, thank you very much. So 679 to 683. Match the description with the associated disease. A. Takayasu arteritis. B. Giant cell arteritis. C. Both. D. Neither. So the option here is 679. Occurrence is predominantly in women. 680. Onset is typically during teenage years. 681. Jaw muscle claudication suggests the diagnosis. 682. Fever is almost always present. 683. Stereotherapy is cornerstone of management. Okay, so for Takayasu arteritis and giant cell arteritis, Takayasu arteritis is the way I've coded it is that it's most times the opposite of giant cell arteritis. So you see it commonly in people less than 50 years, while GCA is commoner in elderly people 50 years and above. For Takayasu, I think it's commoner in females, although I've been told now that GCA is also in females. Then what else about it? Takayasu can occur teenage years or teenage years to adulthood. Then fever is almost always present. Well, that almost always is looking somehow. I know they have fever for GCA, but I don't know whether it is almost always present in them. So looking at this 679, I will be taking option A as the correct option. Onset is typically during teenage years. I would think that the correct option will be A2. Jaw muscle claudication suggests the diagnosis, like I said earlier, for giant cell arteritis. Most likely, like it has been said, they describe headache, jaw muscle claudication. They also describe sudden onset blindness. Then there's also amaurosis fulgens, if I can remember very well. So that one will be B. Fever is almost always present. I will leave that 682. 683. Yes, they use steroid for management of both. So I'll pick option C for that. For 682, the question looks somehow. Fever is almost always present. Well, maybe I will pick in option D for that. I don't know. Contribution, please, from the class. Please, am I audible?
Yes.
Yes, you are very audible. Yes, yes.
Okay, please, I need contributions.
As for 682, fever is almost always present. I think that goes for giant cell arteritis. As opposed to 679, the occurrence predominantly in women, that is for C. As is for both now, that's Takayasu and giant cell arteritis.
Yes, I was just corrected about that. Okay, yes, thank you.
Thank you.
Okay, what about 682?
That's giant cell arteritis.
Okay.
Fever is always present is in giant cell arteritis.
Okay.
Yeah, but in giant cell arteritis, fever is about like 12%. So you probably have to look at it well, because if you say fever is almost always present, I mean, once there is almost always present, you have to be very careful in choosing that. Whenever you see that in MCQ, I mean, it's not always like that, but at least you have to ponder a bit. So I'm looking at a percentage of about 12%. I don't know if that qualifies for almost always present for GCA.
Thank you so much. Sincerely, I would have gone. But what's the answer in the book? I would have gone for neither. So I would have gone for neither. Maybe D.
That's what I would choose. I think it's neither. Fever is almost always present. It's neither, because once it's not above 50%, I don't think that is almost always. Almost always. That's like big. So if you are looking at 12%, certainly it's I don't think it gets the threshold to consider as almost always.
Okay. Thank you.
Okay, I just checked now. I think the textbook equally supports that the giant cell arteritis. I've not been able to go through the details to know the percentage they gave you anyway. Thank you.
They are quoting 12% here, so
Okay. Dr. Urimalade, are you ready to take your part or should I continue? Sorry that I've taken parts of your questions. It's in blocks.
No problem. So continuing with question 684. 684 to 688. All right, thank you. Thank you. Question says, match the chemotherapeutic agent with the likely cardiac complication. A, myocardial infarction. B, acute myopericarditis. C, atrial fibrillation. D, arrhythmia acutely and dilated cardiomyopathy chronically. Then E is hypertension. So the drugs are 684. Okay, let me just say 684 is ibrutinib, which is a tyrosinase kinase inhibitor. Also 688, which is sunitinib, is equally a tyrosinase kinase inhibitor actually, and they are used for different malignancies. But basically, that's a class of drug which they belong. 5-fluorouracil, that is 685, cyclophosphamide, and doxorubicin 687. Doxorubicin is an anthracycline, and the cyclophosphamide is an alkylating agent. So now to the toxic or side effects or complications, cardiotoxicity that they cause. The doxorubicin, which is anthracycline, I would like to start with that. That will cause DCM chronically and acutely. It could also cause different types of arrhythmias, ranging from either an SVT to even sinus tachycardia to start with. Then you can have atrial fibrillation, flutter, as the case may be. Those are the predominant arrhythmias that they cause, really. Then that would make 687 to be D. Okay. Then cyclophosphamide, that's 686. Cyclophosphamide will primarily cause acute myopericarditis. That's the major toxicity that they will cause. That will be B for 686. Then for fluorouracil, that's 685. That will cause myocardial infarction. Specifically, it causes spasms of the coronary vessels. So it will cause a non-obstructive coronary myocardial infarction. That's the MINOCA, to be precise. So that's what the 685, which is fluorouracil, will cause. Then for ibrutinib, that's and sunitinib, those are the tyrosinase kinase inhibitor, but specifically the sunitinib will worsen or will cause hypertension, really, whereas the ibrutinib will, on the other hand, will cause atrial fibrillation and also any form of arrhythmias, most specifically supraventricular arrhythmias is what they will cause. But before I leave those questions, I would like to also say that almost all these drugs will be toxic in one way or the other to the heart, but we are just trying to mention the specific one that is pathognomonic for a particular drug or class of drug. Is although all of them actually could cause failure at one point in time or the other. Thank you. Don't know if there are contributions or additions to what I've said.
Go ahead, please.
Okay. So 689, it should be 689 and 690. But I think there are rounds of questions too. So I'll be picking 689 to 693 if the person to take it does not really mind. So 689 reads, you have to match the abnormality or the endocrine. Sorry, I've forgotten the questions now. Why it was framed with the. So, okay, match the cardiac finding, yes, with the most likely endocrine abnormality. So we had to match cardiac findings with most likely endocrine abnormalities. So the endocrine abnormalities include, sorry, please could we, there is hyperparathyroidism there, there's hypothyroidism, there's Cushing's syndrome, there's hyperaldosteronism, and also hyperthyroidism. So hyperparathyroidism, hypothyroidism, hyperaldosteronism, Cushing's syndrome, as well as hyperthyroidism. So 689 says U waves on the electrocardiogram. Well, I would like to say, since these are associations, I would like to pick them as the way to fit so that it doesn't confusing. So we have U waves, we have cardiac myxomas, means Lehman scratch, short QT interval, as well as pericardial effusion. So the simple thing to just go by here and forget about is the pericardial effusion, which will be similar to what is scenario within hypothyroidism. So that leaves 395 to B. All right. So then looking at the means Lehman scratch is classically seen actually in hyperthyroidism. It's said to be a mid systolic murmur that is best heard on the left second intercostal parasternal space, which is actually a mid-systolic murmur, and it's classically seen in hyperthyroidism. So 691, that is E. Okay. Then looking at U waves, that's 689. U wave, we'll know that we'll see classically U waves in things like hypokalemia, and hypokalemia will be seen in this instance. Out of all the options here will be hyperaldosteronism. You know, they have hypokalemia, they have metabolic alkalosis too. So that leaves option 689 as hyperaldosteronism. That's U wave. Then 692 short QT interval. Short QT interval would be caused by things like hypercalcemia, in contrast to a long or a prolonged QT interval that we see in cases of hypokalemia, hypocalcemia, hypomagnesemia. So hypo, in this setting, the things out of these options that could give the hypercalcemia would be hyperparathyroidism in the context of these questions that we have here. So that leaves us to cardiac myxoma, which would easily be fixed with Cushing's syndrome. That's 690. The Cushing's syndrome is actually a constellation. If we are to link it together, would be this Cushing's syndrome that we'll have, where there is cardiac myxoma occurring with skin lesions, multiple skin lesions, and then also endocrinopathies. And the endocrinopathies could include Cushing's syndrome, could include what's the name now? This hypersecretion of the, what's the name of this? Sorry, I'm trying to remember, that causes reduced that's, what's Addison's now, please? Sorry, I just need help. I'm already sleepy. So, and other things too could be, sir?
Addison's is adrenal insufficiency.
Yes, adrenal insufficiency and sir?
Hypocortisol.
Yes, hypocortisolism and those, and we can also have things like acromegaly too there as part of the endocrinopathies usually, so which could be Cushing's, hypocortisolism, acromegaly, and some other multiple endocrine dysfunction. That's the Carney's syndrome. So that makes our 690 to be option D, to be correct in that instance. Thank you. I think that ends my own
Thank
aspect.
you, Dr. Rima. You've
Thank you.
taken part of my question.
Sorry, I'm sorry about that.
No, you're far too kind. Okay, I'll take you.
You take someone's own too now.
Okay.
Yes, you finish the whole thing now.
The way they shared it. Thank you, everyone.
Okay, I'm taking 694 to 697. Is all about the fibrolytic agents. Where we have the TPAs, how they act. They are naturally occurring from the endothelium of the cells and the vascular tissues. And there's some of them, you have the fibrin specific ones and the other ones that are not. The fibrin specific ones are the OTPs, which is the first generation antifibrinolytic. It's fibrin specific. And also the other ones, you have the tenectepase, which has the highest fibrin specificity. The half-life of the said to be between 20 and 34, and that's why it's given as a single bolus. Then there's also the reteplase, which is like the second generation TPS. It's said to be, unlike, not fibrin specific. How it doesn't really bind to the fibrin surface. All it does, they say it penetrates the surface before it acts. And then you have the non-fibrin specific, the streptokinase, which is gotten from Strept hemolyticus. And then as such, they said how it is, it doesn't bind to, it carries out its activity by forming a complex with the plasminogen, and as such, it converts the plasmin is converted to the plasmin, where it's helped to block the clots. And then you have the other ones, the urokinase, which is gotten from the renal tubular cells, and it said it's used commonly even in USA for cases of intravascular thrombolysis too. So I think I can go to the person 694. Both single and two chain. Okay, match the description of hello.
Yes, we can hear you. Go ahead, we can hear you.
Match the description to the associated fibrinolytic agent. A, you have the streptokinase. B, tissue type plasminogen activator. C, urokinase. And D, tenecteplase. 694, both single and two chain forms demonstrate proteolytic activity. This describes the tissue type plasminogen activator. Initially, it has a single gene which is converted to two chains to form the proteolytic activity, and then synthesized in renal tubular cells and endothelial cells. This describes the urokinase. The prolonged half-life allows administration as a single bolus. This describes the tenecteplase. And 697 must form complex with plasminogen to exhibit enzymatic activity. That is the streptokinase. And it says it has to be given in a large bolus because of in order to overcome the antibodies that are associated with it. So you have to give large doses of the streptokinase. Thank you. Are there questions? Addition? Hello?
Move on, please. If anyone has questions, I will call your attention to it.
Okay. Thank you. They match the finding to the associated anticoagulant. Well, the anticoagulant, you have the unfractionated heparin and the low molecular weight heparin. The unfractionated weight heparin, it acts by binding to the thrombin, and in addition to the thrombin, also bind to factor 9, 10, and 11 before bringing on its function. And then in doing so, it's because of this, of course, it's the major side effect is the HIT. You have the type 1 and type 2. The type 1 is non-immune mediated. It occurs 2 days after the administration of heparin, and the type 2 is said to be immune mediated. Occurs 2 to 3 weeks after the administration of the heparin. That's the type 2, and they're usually like the 40s of the type 2. The major side effect of the H2 is said to be associated with the type 2. It has to do with the timing of the administration. The type of heparin, the thrombocytopenia, and the thrombosis. And they said in the HIT patient, they have more commonly, they have more of a VT as opposed to bleeding, venous thromboembolism. So, and their major side effects, it has increased vascular permeability. It can cause hyperkalemia, even the increased vascular permeability, thrombocytopenia, and all that. While the low molecular weight heparin acts by binding to factor 10, and then the unfractionated can measure it with the help of APTT. Low molecular weight heparin acting via the it also acts through the antithrombin, but majorly from factor 10. It can also has there's been incidents of HIT with them, but lower cases have been reported. Of course, you can measure it, and then you don't need repeated monitoring with lower molecular weight heparin. And then the bioavailability of the low molecular is said to, when giving subcutaneous, is said to be greater than 90%, as opposed to the unfractionated, where it's said to be about 30% bioavailability when giving sub. You can give it IV and subcut. They said when giving subcut, the bioavailability is about 30%. So 698, the hyperkalemia. I said it's one of the side effects of the, it causes hypoaldosteronism, and in doing so, it leads to hyperkalemia. So 698 is A, that is the unfractionated prin. 699, bioavailability after subcutaneous injection is greater than 90. That's B, low molecular weight prin. And then inactivate blood-bound thrombin. I think neither of them do so. Thrombocytopenia, both of them can lead to thrombocytopenia following an HIT. So you have lower incidence of that with low molecular weight prin. Increased vascular permeability, that is the unfractionated prin.
Stevens, you can just finish up.
Okay. And then the 703.
I'm the one in the last part.
Oh, Stevens, do apologies. You're welcome, sir. I don't know you're around, sir.
Okay.
He's
Okay.
not a star.
You're welcome, sir.
That's Dr. Lagbira.
Yes.
Yeah.
Okay.
I went to the Wonderland, but I'm back. Thank you.
Yeah.
You're welcome, sir.
For helping me. The first
Thank
two.
you.
Okay.
Listen
Okay,
there.
so the last four. Match the following complications with the associated rheumatologic disorder: otitis and headaches, Lieberman-Sachs endocarditis, pulmonary atrial hypertension, aneurysmal dilatation of the subclavian and carotid arteries. So the questions are Behcet's syndrome, SLE, giant cell arthritis, and systemic sclerosis. Okay, so for Behcet's syndrome, Dr. Adeyeju earlier explained. Behcet's syndrome is actually a rheumatological disorder that affects the thoracic aorta and its branches. So, subclavian artery and carotid arteries are branches of the thoracic aorta. So, it causes inflammation of the thoracic aorta and dilatation of the aorta and its branches. So, 703 will be D, aneurysmal dilatation of subclavian and carotid artery. Then 704, systemic lupus erythematosus, is a cause of Lieberman-Sachs endocarditis, which is a form of non-bacterial IE, in which there can be vegetations on the mitral valve, that's the atrial side of the mitral valve, or vegetations on the aortic valve, that's on the arterial end of the aortic valve. So SLE is Lieberman-Sachs. Then 705, giant cell arthritis. Okay, giant cell arthritis is also inflammation of is associated with inflammation of the proximal aorta. So A will be correct. Is associated with aortitis in about 15% of patients. And we also know that it causes headaches because it's also known as temporal arthritis. It's commoner in women greater than 50 years of age. Then 706, systemic sclerosis. Systemic sclerosis, the option will be C. We know that most rheumatological disorders are associated with pulmonary hypertension, especially the type 1. But the commonest among them is systemic sclerosis, even though SLE2 can give pulmonary hypertension. But the commonest rheumatological disorder that causes pulmonary hypertension, especially the idiopathic type, is systemic sclerosis. Thank you.
Thank you very much, Dr. Labwe.
You're welcome, sir.
Beautiful. Chief Usoke, I'm thinking there is this block part 2 in 50 to about 600. We've taken some part of it. I'm thinking that if it's possible, if the class agreed, that we can quickly take that part 2. Is there a block question, so it shouldn't take us much time if all of us work together. It's just a suggestion, Chief Usoke.
And the people presenting them are not ready with them, I guess.
I've private chatted like 7 people, no response. So,
No problem. Let me go there now.
Okay. If we can quickly do it, at least till 11:30 or thereabout. If we can all work together.
The 5 what?
I think it's 571. We've done 550 to 570 yesterday. So I think it's 571 to around 600, but they are in blocks. And Dr. Adedeji has already done his part around 591. So it shouldn't take us much time. I know the chiefs are here that will guide us with the answers. Um, 571, we've done all this part yesterday. Yeah, I think 571 has been done yesterday. So it's from 572. I don't know. Is Dr. Oloma ready? I can see her on the platform. Dr. Oloma, are you ready to take your part? Okay. Chief was okay. Will you read or I should just read and we'll all do it together?
Okay. Match the question number 572 to 575. Match the description with associated form of therapy for pulmonary embolism. Unfractionated heparin or low molecular weight heparin, A. B is fibrinolytic therapy. C is both. D is neither. Now, 572 may be effective in pulmonary embolism even 1 to 2 weeks after the onset of symptoms. I'm considering A there. I don't know what everybody thinks. 573, dissolution of recently formed thrombus is a major action. That's B now, fibrinolytic therapy. 574 should be administered along with antiplatelet agents. For that should be unfractionated heparin. And 575 may suppress aldosterone secretion. I think that's unfractionated heparin again. Thank you. More contributions, please. Others, I will go to the answers and read it out. Hello, I hope I'm audible, please.
Yes, you are audible,
Yes,
sir.
you're audible.
Please contribute.
You are laughing, eh?
The way you said you will
Yeah,
go
so
to check it.
yeah, so I think the aldosterone secretion, there's 575. I agree. It's I'm not sure whether it's actually unfractionated or low molecular weight. I thought it was actually low molecular weight heparin. The 575, even though I mean it's together, but I mean just for out of curiosity, I thought the suppression was more related to the low molecular weight heparin than the unfractionated, because of the role it has on the down regulation of angiotensin II receptors.
Well, 575 is unfractionated heparin, so it's correct. Yes. So 575 is A.
Mm.
574, on the
Well,
contrary,
let me pick it from the answers. 572 is C.
okay.
572 is C. And what is unfractionated heparin has been historic therapy for pulmonary embolism, and is also a porcine or bovine-derived glycosaminoglycan that acts by binding to antitrophin. This is long, and long. They also talked about the low molecular weight. It's a long story here, but the implication is that both fibrinolytic therapy and then the low molecular weight heparin and then unfractionated heparin can be used effectively in pulmonary embolism for up to 2 weeks after onset of symptoms.
Thank you very much.
Mm-hmm.
Then follow up for 7.3 and 7.4 then.
Okay, 573 is B.
Okay.
That's correct. Dissolution of recently formed thrombus is a major action. The answer is B. 574 should be administered along with an antiplatelet agent. The answer is D, neither of them.
Oh, I think it should be neither. Sorry. It's neither. I just looked at it now.
Yeah. Then 575 may suppress aldosterone secretion. That just as we discussed somewhere that caused yes, that's A. If we go back to the last question we discussed that caused hyperkalemia, right? That's A. Is there any need reading the long response?
I don't know what others think. I think it's unnecessary.
Okay.
Please kindly continue, sir. Thank you.
Are they Andrew?
Sir, yes, Chief.
But importantly here, they said fibrinolytic therapy for pulmonary embolism may be efficacious when used up to 2 weeks after onset of symptoms.
All right, sir. All right, sir. Thank you, sir.
Okay.
Question number 576 to 580. Match its description with the associated condition. Hemochromatosis, A. B is amyloidosis. C is both. D is neither. I think I should love this question. May result in restrictive cardiomyopathy, both to Jare. 577. Early stage disease is irreversible with chelating agent. It's reversible with chelating agent, of course, hemochromatosis. 578. Ventricular tachyarrhythmia is most common initial presentation. Tempted to say both because I can see both have arrhythmias. I'll come back to that later. Let's say arrhythmia. Okay. Autosomal recessive inheritance may be responsible. That is hemochromatosis. That is A. because B is actually an aggregate of several things, including leukemias. 580, low voltage QRS on ECG is typical. Well, I'm sure of amyloidosis. Hemochromatosis possibly, but I'm sure of amyloidosis. Comments and further contributions, please.
Okay, let me just add to that. Hemochromatosis, it is autosomal recessive, as you've said, is on chromosome 6. That's where it is. And like you've said, what else? It has a restrictive cardiomyopathy, and if picked at the early stage, you can use chelating agents. For that option 578, looking at both of these things, most of them, I think they present more with features of heart failure. They present later and they present more with feature of heart failure. In fact, you won't pick an early, it's unlikely that you pick an early hemochromatosis. So both hemochromatosis and amyloidosis present with features of heart failure. I'm not sure whether they really have, whether the failure ventricular tachycardia is the most common initial presentation. I think so. So those are my contribution. Thank you.
Okay, let me read this before we look at the answers. Because of the infiltrative nature of these conditions, as hemochromatosis and amyloidosis, each initially lead to a stiffened myocardium, and usually present as a restrictive cardiomyopathy. In later stages, however, dilatation of the ventricles may ensue. Although arrhythmias are common in both conditions, breathing disorders are not usually prominent initial symptoms. The ECG in hemochromatosis usually show diffuse ST segments and T-wave abnormalities, as well as supraventricular arrhythmia. So the point they're trying to make is that in the early stages, the arrhythmias are not usually prominent symptoms. So if we now use this to go to the answer section, 576, the answer is C. Both of them will lead to restrictive cardiomyopathy. 577, the answer is A. That's hemochromatosis as rightly answered. Early stage disease, irreversible chelated agents. And 578.
Neither.
The answer is D. Neither. Yes, neither. Ventricular arrhythmias, as we read out, is not common in the initial stage, but here they said is the most common. 579. The answer is still A, as we've already answered. And then 580. The answer is B, as we also answered.
Thank you very much, Chipoye. More contributions and more comments, please, before we move on.
Sorry, I was just thinking, if hemochromatosis is an infiltrative disease, why is it not giving low voltage QRS complex? I'm just curious.
Let's look at the they said the ECG in hemochromatosis usually show diffuse ST segment and T-wave abnormalities, as well as supraventricular arrhythmia. Abnormal rhythms, especially atrial fibrillation, are also common in amyloidosis. In addition to electrocardiography findings of low voltage, for our amyloidosis now, abnormal rhythm, especially atrial fibrillation, are common in amyloidosis, in addition to electrocardiography findings of low voltage QRS complexes and then pseudo infarction pattern. So the question you just asked is why, if it's an infiltrative condition, why is it not associated with low voltage complexes?
Yes.
I think we may also try to relate this. Does hemochromatosis affect the lungs? If it doesn't, because if you amyloidosis also has, I think it has an effect on the lungs also, and so on. That may also be part of what is dampening the effect of the ECG.
Okay. I don't know. Let me just try. If you look at that option D, it says low voltage KRS on ECG is typical. I think the thing here is the typical thing that they are putting there. And you know, most of our amyloidosis, that's what we find. But the reason why in hemochromatosis why you are not finding low voltage, I wouldn't know. But it's possible that we could also see low voltage in hemochromatosis, just that it is not typically seen.
That's true. That's true. Mm.
Okay, hello, can you hear me?
Yes, Dr. Sarah.
All right. In amyloidosis, one of the major reasons why you're having attenuation of your ECG waves is because the amyloid proteins that are being deposited in the myocardium create some form of electrical impedance. Okay, am I audible?
Yes, we are with you.
Yes, it causes some form of a kind of electrical impedance. So that is why you find attenuation of those ECG voltages. Now, in contrast to when you contrast it to, let's say, hypertrophic cardiomyopathy, there is no actually any form of increase in the myocardium, the myocardial cells. It's just that in between those myocardial cells, there's a deposition of those amyloid proteins, and they create that electrical impedance, and it now dampens the electrical activity. That is why it's reflected on your surface ECG as low voltages. So when you compare it with hemochromatosis, hemochromatosis is a deposition of iron. Deposition of iron cannot create electrical impedance. Rather, it will exaggerate a lot of conduction. That's why you get to see arrhythmias and several other conduction. Thank you.
Sawa, thank you. You're really taking us back to basic science.
Thank you. Please, I would like to contribute to this. Hello? I don't know if you can hear. Okay. Concerning this question, basically what causes low voltage is if there's dampening effect, like come from fluid, water, whatever it is, air. I think all infiltrative connective tissue disease cause low voltage QRS, all of them, because of the deposition of these substances on the myocardium. They are all causes of low voltage QRS. But I think what separates this out is that the fact that they are talking about maybe like in amyloidosis, it's a very significant feature. In hemochromatosis, it is there, but it might not be their standout feature, like other ST changes and all of that. So I think that is the reason, not that hemochromatosis does not cause low voltage QRS. I think it does. Thank you.
All right, thank you very much. Can we move on, please? Enough of the contributions. Thank you. Question number 581 to 585. Match each description with the associated condition. A, tricuspid stenosis. B, pulmonic stenosis. C, both. D, neither. Well, 581, usually rheumatic in origin. That should be tricuspid stenosis. 582, typical of carcinoid heart disease. Okay, that's pulmonic stenosis. That's B. 583, most adults are asymptomatic. And that's pulmonic stenosis. 586, ascites is a common or physical examination. I think both can actually cause that, at least in the advanced stages. C, 585, balloon valvoplasty is the treatment of choice. I think both. I think pulmonic stenosis, I'm sure of that, but I think I'm more likely to pulmonic stenosis, but I'm not very sure of tricuspid stenosis. Thank you very much. More comments then and contributions.
Okay, 582 should be both. If you remember yesterday, I talked about carcinoid heart disease, where I said that the vasoactives, if they are coming from the liver, they affect the right heart valves. So both tricuspid and pulmonic, they affect it. Thank you.
Thank you very much. Chief Oyebeze, do you have the answers ready? Hello?
Hello?
Yes.
Hello? Okay,
Yes.
let me just mention a line from the response in the answers. They said the most common form of pulmonary stenosis is congenital. A rarer form results from carcinoid plaques. The latter cause constriction of the pulmonary valve ring, retraction and fusion of the valves, and then pulmonary stenosis with or without pulmonary regurgitation. Carcinoid heart disease can also involve the tricuspid valve, but most commonly leads to tricuspid regurgitation. Are we clear on that? Hello?
Yes.
Yes, we are.
Okay, so that would actually, of course, what the last speaker said is correct, but from the summary here, they say most commonly leads to tricuspid regurgitation. So that takes away the answer. So if we now look at the answer, 581 is A, as Riley said, that's tricuspid valve, usually rheumatic in origin. 582 is B, typical of carcinoid heart disease, pulmonary stenosis. So if we had had a tricuspid regurgitation here, that would have also changed the response. 583 is also B. Most adults are asymptomatic, so is pulmonary stenosis. That was also rightly answered. 584 is A. Actually, 584. Ascites is common on physical examination. It's tricuspid stenosis. The answer, yeah. 585 is B, as rightly answered. Balloon valvuloplasty is the treatment of choice.
Thank you, sir. More comments, please.
Okay, concerning one, okay, I just want to add this. I think there's something my consultant always say, that rheumatic heart disease hardly affects the pulmonary valve. I think the mitral first, followed by the aortic, then the tricuspid, then rarely pulmonary valve. Thank you.
Okay, thank you.
The sequence in our environment is mitral, followed by mitral and aortic, then aortic, tricuspid. That's for rheumatic valvular heart disease.
Okay. So in relation to the balloon valvuloplasty, it's also mentioned that mostly with pulmonary stenosis, usually the transvalvular gradient is greater than 50 millimeters of mercury for patients who are symptomatic, then you want to do the balloon valvuloplasty for. But if they are
symptomatic, then you are looking at a high gradient of system limiters of mercury. And since this procedure requires an intact valve, usually patients who have hypoplastic pulmonary valves would rather require a valvotomy, like in Noonan syndrome and all that, or maybe people with dysplasia of the pulmonary valve. So that's one thing that we should also know.
Thank you very much, sir. In absence of further comments, do I move on, please?
Yes, sir.
Ade, you said we should move to 600, right?
I said that we should move on, sir.
Yes, ma'am.
Thank you.
Questions 586 to 589. Match each description with associated drug therapy in patients with idiopathic as group 1 pulmonary arterial hypertension. A, calcium channel blockers. B, epoprostenol, that's prostacyclin. C, both. D, neither. 586. Studies have shown a survival benefit in patients with pulmonary arterial hypertension. And we have calcium channel blockers and epoprostenol. I think I'll go for epoprostenol.
I agree.
Hey, God. Okay. 587 should be started empirically in all patients with group 1 pulmonary arterial hypertension. Empirically. 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 Okay.
I think this is false because the calcium channel blockers, you don't start it empirically until you have done your vasoreactivity testing.
Reactive test, so it's neither.
And it is positive. So I am very sure of calcium channel blockers in pulmonary hypertension. You do start empirically. So if they are saying for calcium channel blockers is false. I'm not sure for the epoprostenol.
Yeah, so the truth is, I mean, what you said is right. So it's only just a small percentage of patients who show positive vasoreactivity in the cath lab. Only a few patients will respond to calcium channel blockers, just probably less than 40%. So even then, it's guidelines-wise. You wouldn't want to start it empirically in every patient. And then if you look at isoproterenol, if you look at most of the study that has been done, they don't jump straight away to the higher drugs. But some of the recommended guidelines require that you start from like sildenafil, tadalafil, and all that before you step up. So empirically, I think it will be neither. So to start that empirically will be a no. That's my thought.
With your reason, I think it is inclining towards neither really, because I've seen several pulmonary hypertension, and I can't remember ever using epoprostenol as to start as a baseline while the investigation is going on.
Sorry, is in Nigeria?
Hello, man.
I say it's not even in Nigeria. I don't think I've ever seen it.
You see, yes. We see more of Ryosigua and all that.
Okay, please, I just want to make a contribution. I know I discussed pulmonary arterial hypertension this evening. So for the first option, studies have shown a survival benefit in patients with PAH. I think it's both, because if the patient actually responds to calcium channel blocker after you've done the vasodilating reactivity test. The patient will have an increased survival benefit, is except the patient does not respond. So I think that qualifies CCBs and and epoprostenol to be survival benefit. So question 586 should be both. And then it was some grade less than 50% was what I saw for CCBs. Then should be started empirically in all patients with group 1 PAH. So we don't start any of them empirically until you've made a diagnosis for the epoprostenol, and then until you've done the vasodilating reactivity test, just like he has said. Then not approved for oral administration. Epoprostenol, we don't give it orally. It's basically subcutaneous, and then they have the IVs also. And I think they have one that is now inhalation now. Then exert antithrombotic effect is basically the prostacyclins that have antithrombotic effect. Thank you.
Thank you, Chinene. Professor, more attention. More contributions, please.
Yes, so I think that we need to define the definition of survivor benefits, because we need to be sure whether with those who benefit from calcium channel blockers, usually the administration is short-term. And so we need to find out whether they benefited in terms of quality of life in relation to the assessment network test or survivor as in mortality. I think that's what we look at. We have to look at the primary endpoint and the secondary endpoint. That's how I think that's the best way to answer that question. I mean, looking at benefit, yes, they benefit, but survival, that's the key word. We know isoproterenol, there is no argument about it. There is survival benefit for the prostacyclin, but for calcium channel blockers, we need to be sure. That I'm not sure whether there is benefit, but is this survival benefit? I think if we're able to answer that question, if we're able to find out what it says, because some of the recommendations are based upon benefit that are not mortality related. Sometimes it's just quality of life, 6-minute walk test and all that.
All right, sir. Can somebody help us read the answers, please? Can anybody help us read the
Let's look at the answers quickly. 586, the answer is C, both. So both have shown to have a survival benefit in patients with pulmonary arterial hypertension. 587, the answer is D. 587. Neither of them should be started empirically in patients with group 1 pulmonary artery hypertension. 588, the answer is B. That's the prostacyclin. So that's 588, not approved for oral administration. I'm going to read some part of it. Then 589, the answer is also B again. That's the prostacyclin. But let's quickly look at some extract from what they said. Calcium channel blockers and prostacyclin are two forms of vasodilator therapy used in the chronic management of patients with idiopathic group 1 pulmonary arterial hypertension. They are prescribed to carefully selected patients with hemodynamic guidance. Then reading down a little, they talked about chronic intravenous, they're now talking about the route of administration. Chronic intravenous prostacyclin administration has been shown to improve symptoms, quality of life, and survival in patients with idiopathic pulmonary arterial hypertension. It also demonstrates antithrombotic effect that may be of benefit in the management of the thrombo-occlusive component of pulmonary arterial hypertension and may help restore the integrity of the pulmonary vascular endothelium. epoprostenol therapy is, however, cumbersome because it requires a surgically implanted intravenous catheter and then an infusion pump system. The prostacyclin analog, iloprost, which is by inhalation, and then the treprostinil, subcutaneously or by inhalation, improves symptoms and are more easily administered, but evidence of survival benefit is lacking. So from what we've read so far, there is no oral route of administration for the prostacyclin and then the prostacyclin and then the epoprostenol, which is intravenous, and then the analogs are either inhalational or subcutaneous. That's the iloprost and then treprostinil. But these are few of the they also talked about the other ones. Additionally, a group of but before then they talked about the phosphodiesterase type 5 inhibitor, sildenafil, tadalafil, and vardenafil reduce pulmonary arterial hypertension, improve exertional capacity, and are well tolerated. Additionally, a group of endothelin receptor blockers, bosentan, ambrisentan, and mesisentan, improve hemodynamics, symptoms, and stamina in these conditions. Well, the side effects of this group include the peripheral edema and hepatic toxicity. Thank you.
Thank you, sir.
Thank you so much.
Okay, we are moving on. Or any more contributions?
Let's move on. Let's hit the ground running, Chief.
Thank you very much.
For the Adedeji has done 590 to 601. The other two, we're supposed to go to 602.
Okay. 602, right?
Yes, we've done 590 there. Thank you.
Okay, thank you.
Thank you, Chief Uzoke. And thank you, everyone,
Thank you, Ma.
for allowing us to do this together.
602 to 606, right? Match the following descriptions with the appropriate condition. A, complete AV septal defects. B, complete transposition, that's dextrotransposition of the great arteries. C is both, D is neither. 602, present with cyanosis. Of course, both will present with cyanosis. Both, that's C. Right axis deviation on the ECG. B we have right axis deviation, but with
That's ASD. I don't know.
complete AV septal defect. I think that will may equally involve both the membranous and possibly the muscular part of the ventricular septum. That can also give us right ventricular hypertrophy when there will be torrents, high volume inflow into the right chamber, right atrium, and the right ventricle, and the hypertrophy. I think 603 is 603 is equally both. That's C. I'm tempted to say both there. 602 both, 603 both. 604, an interatrial communication is almost always present. Yes, that is a complete atrioventricular septal defect. That's A. 605, on echocardiography, the atrioventricular valves appear abnormally aligned at the same level. That is at least I think I've seen this one as complete atrioventricular AV septal defect, where we have arterialization of the I think the right ventricle also.
No, but that is Epstein
Fellow
anomaly.
HCs.
That's Epstein anomaly.
HCs.
All right, sir. All right, sir. I think the details will come after. Let me read it. Read the last one. 606. A high-pitched decrescendo diastolic murmur is common at the left sternal border. Left sternal border. That is a septal defect. Yes. I think I'll go for that. I go for A. Thank you very much. Comment. So.
Now, wow, this one tough small. Make we read the answer. Chief Oyebuze.
Okay, let's quickly take the answer. But
But
then
people have
let me read.
Okay.
Okay.
Hey, is it my network? I can't hear your voice again. No.
I think it is network.
No, it's not. I thought somebody wanted to contribute more. Okay, let me quickly read. But before I talk about the answer, let me just read this. It's interesting. Complete atrioventricular canal defect, also known as endocardial cushion defect, comprise a group of abnormalities in which the common features are: one, absence of the membranous and muscular atrioventricular septum. Then causing the atrioventricular valves to appear at the same level on echocardiography. So if 2/outlet disproportion result in an elongated left ventricular outflow.
Sorry, the network. I don't know.
Goose on angiography.
Hello,
Is it Paul with every other person? Hello.
Maybe
yes,
it's from
we
my
can't hear you. No, we can't hear him too.
Okay.
Oh,
Let me
I can't
change. Let me see if I can change.
Maybe nearby mango tree or something.
Hello.
Hello, sir.
Can you hear me now?
Yeah, the mark, we can hear you.
Okay. 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 I was reading. I said before we look at the answers, I think it's interesting we read this. They say complete atrioventricular canal defect, also known as endocardial cushion defect. So it's a different entity from the Epstein anomaly we are thinking. So it's endocardial cushion defect. That's the complete atrioventricular canal defect. Comprise a group of abnormalities in which the common features are: one, absence of the membranous and then the muscular atrioventricular septum, which causes the atrioventricular valves to appear at the same level on echocardiography. Two, an inlet/outlet disproportion, inlet to outlet disproportion resulting in an elongated left ventricular outflow tract, which produces a gooseneck deformity on angiography. Three, lateral rotation of the posteromedial papillary muscle. And then 4, abnormal configuration of the AV valve. For example, the left AV valve is trileaflet with a cleft appearance. So they say for the infants usually present in the first year of life with a history of poor weight gain and frequent respiratory infections, and then heart failure is also common. On physical examination, several murmurs may be present, including a holosystolic murmur along the lower left sternal border due to ventricular septal defect, a holosystolic murmur at the apex due to mitral regurgitation, and then a right ventricular outflow tract systolic murmur. Because the direction of intracardiac shunt is left to right, cyanosis is not typical. Typical electrocardiography findings include a left axis deviation due to the left anterior fascicular block and an incomplete right bundle branch block. Echo is usually diagnostic for this condition. What the other one now talked about the complete transposition of the great artery. We have talked about that before. The aorta arises from the morphologic right ventricle, and then the pulmonary arises from the morphologic left ventricle. So this anatomic arrangement results in two separate and parallel circulations. Some communications between the pulmonary and systemic circulation must exist after birth to sustain life. Almost all patients have an intra-atrial communication. 2/3 have a PDA and 1/3 have associated VSD. The typical clinical manifestations are dyspnea, those ones are. So I think the major points we needed to note, I've read them out. So if we take this to answer the questions, am I still being heard?
Very well, sir.
Okay, if we take this to answer the question, 602 presents with cyanosis. We already know the answer already. 602 presents with cyanosis. The answer is B. That's the complete transposition of the great arteries. 603, right axis deviation. The answer is still B. Then 604, an intra-atrial communication. Well, the answer is both from what we read out. 605, the answer is A. That's the 605 on echocardiography. The atrial valves appear aligned at the same level. So the answer is A. Then 606, a high pitch crescendo diastolic murmur are common at the left sternal border. The answer is also A.
Sir, please, what is 603? Sorry.
Okay, 603. The answer is B. Right,
Okay.
as is deviation on ECG.
Thank
The answer
you,
is B.
sir.
But let me just, incomplete transposition of the great arteries, the aorta arises from the morphologic, I've read this before. These anatomic, I'm going to the ECG findings. Some communication, of course, exists between the pulmonary and systemic circulation. That's for the transposition of the great arteries. For that communication must exist for life to sustain after birth. Almost all patients have an intra-atrial communication. 2/3 have the PDA, and then 1/3 have VSD. The typical clinical manifestations, we already said, dyspnea, cyanosis, progressive hypoxia, and congestive heart failure. Cardiac murmurs are absent, unlike the endocardial occlusion defects. In transposition of the great arteries, cardiac murmurs are absent or insignificant in 30 to 50% of patients with transposition of great arteries, and an intact, great arteries, and then an intact ventricular septum. So in infants with transposition of great arteries and a large PDA, fewer than half have the typical continuous murmur of aortopulmonary connection. Now, ECG findings include a right axis deviation, right atrial enlargement, and right ventricular hypertrophy. Echo is usually diagnostic for identifying the abnormal great vessels in relationship to their accompanying abnormalities. So I think it's clearer now.
Yes, thank you, sir.
Thank you, sir. We'll go to question 607 to 611. Match the following descriptions with the appropriate condition. Thank God everybody's here. Catagna syndrome, Holt-Oram syndrome, Leopard syndrome, Noonan syndrome. Then, we've done this before. Web neck, pulmonic stenosis, left anterior fascicular block. Options, please.
I think that may be D. I'm not sure. I think so.
Okay. Deafness, web neck, no, deafness, pulmonic stenosis, complete heart block.
That's no now.
Noonan, okay.
It was 607.
Sorry?
I'm asking that was 607.
You
No,
asked, you said you gave the option and you're still asking.
We eventually cross-check the answers actually.
Okay,
we took your suggestion and moved to the next one.
Okay, sir. Thank you, sir.
Okay.
609, lentigens, pulmonic stenosis, PR prolongation. That should be leopard.
That's leopard, yes.
Yes. 610, sinusitis, dextrocardia, bronchiectasis.
That's Katangena.
Tangina, yeah.
That's again, I think I can remember that much. Abnormal scaphoid bone, atrial septal defect, right bundle branch block.
That's Oram syndrome.
Madam, you are hot this night, so. What,
Let's
could you help us
check
with that, please?
Maybe I should close the answers.
I remember doing this question earlier on in this textbook, but I've just forgotten. Just they read and they forget, they read, they forget.
The answer, sir.
Okay, let's look at the answers. 607 is D. That's Noonan syndrome. Noonan syndrome is a relatively common 1 per 1,000 genetic disorder with autosomal dominant inheritance. About one half of the patient have mutations in the PTPN11 gene on chromosome 12. This syndrome is characterized phenotypically by short stature, a unique facial appearance, mild cognitive impairments, webbing of the neck, cryptorchidism, and renal abnormalities. Approximately half of all the patients with Noonan syndrome have congenital heart disease. The most common lesion of which is valvular pulmonic stenosis. The ECG commonly displays the left anterior fascicular block. Approximately 20% with Noonan syndrome have accompanying atrial septal defects or hypertrophic cardiomyopathy. And that's what they just picked here. The webbed neck, the pulmonic stenosis, the left anterior fascicular block. Now, 608 is C, that's the leopard syndrome. And then briefly, the leopard syndrome is also a rare single gene complex of congenital malformation. The acronym leopard symbolizes the main components of the syndrome. Oh, that's good. The lentigen, then E. This E, I don't know whether it's immunoglobulin what or whatever. E, then electrocardiographic conduction defects. Oh, okay, yeah. L stands for lentigen. E stands for the ECG abnormalities. O stands for ocular hypertelorism. P, pulmonic valve stenosis. A, abnormalities of the genitals. R, retardation of growth. And then D, deafness. So that's what the leopard stands for. So if we now look at the answer they gave here in 608, we have deafness, and then we also mentioned it here as D. So deafness is there. Pulmonic stenosis is coming for P. Complete heart block is under E. That's the ECG abnormalities. So that is okay, took some components of the leopard syndrome. So the leopard syndrome, the leopard stands for the components of that. So then 609, lentigens, pulmonic stenosis. 609 is also C. Is also part of the ECG abnormalities, the PR prolongation. 610, the answer is A. That's well, if we look at what they mentioned here, the Catagna syndrome is an autosomal recessive disorder that the primary defect of which has been elucidated by electron microscopic investigation of the cilia from affected individuals, including bronchial mucosa or sperm. Then the Dennin which are protein structures, and blah, 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 blah. But the important thing here is that the answer is correct for C. Hello?
We can hear you very well, sir.
Can hear you,
Okay,
sir.
okay, okay. The 610, the answer is the Catagna syndrome. Then the 611, the answer is B, that's Hotoran syndrome. We've discussed Hotoran severally, but briefly, Hotoran is a rare autosomal dominant disorder. The classic clinical manifestations is the simultaneous occurrence of congenital heart disease and then an upper limb deformity. So in that option, abnormal scaphoid bone. Okay, that's upper limb deformity. That's upper limb deformity. So it's classical here. So once we have that classic clinical manifestation with congenital heart disease and upper limb deformity, then we've actually clicked it. So the atrial septal defect and then the right bundle branch block. So they give us the answer. So again, 611 is B, Hotoran syndrome. 610 is A, Catagna syndrome. 609 is C. 608 is C, and 607 D.
Okay, sorry, please. I want to say something. I just remembered something now.
Okay.
There was one time we saw a patient that had something that looks like toners, but when we were expecting to see bicuspid aortic valve, but we saw pulmonic stenosis. So they said that's how the diagnosis of Noonan syndrome was made. So when you see somebody, a female that looks like a Turner syndrome patient, but instead of having aortic stenosis, no, bicuspid aorta, they are now having pulmonic stenosis. Think of Noonan syndrome. Then Noonan and Leopard syndrome, they are syndromic causes of hypertrophic cardiomyopathy. Thank you.
Noonan and what is syndromic causes of hypertrophic cardiomyopathy?
And Leopard.
Okay, Noonan and Leopard. Okay, thank you very much.
Yes, they are part of the differentials for HOCO.
Yes. 612 to 615. Match each photograph in figure 4.33 with the condition it represents. A, part A, B, part B, C, part C. That reach where everybody will help. Then, in AFIG, it is, it looks like we have left ventricle, we have right atrial, we have left atrial.
I think you're looking at the wrong images.
Sorry?
I think you're looking at the wrong images.
Okay.
The
Fig
image
four.
you are supposed to use to answer this question is figure
Sorry,
4.3.
I'm in 3-4. Sorry. Sorry, I'm in 3-4. Oh, yes, better. I think I'm okay. I think I'm happier this way. Fig A, we have that lesion at the toe, big toe. Fig B, florid cyanosis of the tongue. C, funny worm-like lesion on the I think that should be I. And D, we have some lesions again on the palm. Okay. Let's go to the options again. Um, 612 says Fabry disease. 613 says infective endocarditis. 614 amyloidosis. 615 systemic sclerosis. Okay, let me quickly jump like this. Infective endocarditis will go for A.
Yes.
Amyloidosis
Amyloidosis.
will go for
B.
B.
B
Yes.
is amyloidosis.
Macroglossal.
Yeah.
Yes, sir. Then Fabry disease should go for
I think C by exclusion.
Yes.
Sorry?
Exactly.
I think
Exactly.
all
C by exclusion.
okay, by exclusion. Okay. Let's go for the other, at least where that we feel a little more comfortable. Systemic sclerosis. That one we can quickly go for that finger. Now that D should be systemic sclerosis.
Yes, you can see thickening of the hand. Then look at the pulps too.
Yes,
Raynaud feature on the pulps of the hand.
Like
So,
ulcers on the of the fingers.
Yes.
Thickness.
So C goes
What
for
are
the
they pointing this arrow to this thing in the eye that looks like a? Is it the vessels or they are pointing at something? Like in the picture in C.
Where is the arrow?
I didn't see any arrow there, man.
Oh, okay. It's from your cursor, like when you were. Oh, sorry.
Yes.
Thank you.
Can somebody read that option C for us, please? At least we have a good idea of the other three. Can somebody read the stories around that option C for us, please?
Chief examiner, sir. Chief.
Okay, let's look at
Hello? I cannot hear anybody speaking.
And that option C.
option C.
Yes,
Option
sir.
C, okay, let me look at the option. Get the option C. Cross-pulse on the retina. All of these, okay, the option C now, the cross-pulse on the retina have the appearance of a fundoscopic examination of cotton wool incident, and consist of aggregations of cytoid bodies. All of these peripheral stigmata of infective endocarditis have become uncommon in the modern era. Any other one?
That's all right, sir. So you say option C, infective endocarditis too?
Which one?
So option C is equally infective endocarditis.
Option C
That's Fabry
is Fabry disease. Then no, option C is only for 612 Fabry disease.
Okay.
Infective endocarditis is option A. That's the Jenway's lesion, right?
All right, sir.
Sorry, so the option C, what disease is that? Because you described it as a rot spot or so.
Yes, option C is describing. Option C is describing the family disease. Let me read that family disease. Family disease
Yes,
is a
sir. Please
sex-linked
read the
disorder.
Fabry disease.
Family disease is a sex-linked disorder that is due to a deficiency of the enzyme alpha-galactosidase A. This disorder is characterized by the accumulation of glycophospholipid within the myocardium, skin, and kidneys. Systemic hypertension, mitral valve prolapse, and congestive heart failure are all common clinical manifestations. Fabry disease may cause restrictive cardiomyopathy. Ocular signs in the disorder are common. Approximately 90% of the patients have corneal opacities, whereas 2/3 of the patients have conjunctival vessel tortuosity, as illustrated in part C of the figure. So what is illustrated in that part C of the figure is the tortuosity of the conjunctiva, inside the conjunctiva. So that's what they just mentioned here. They said approximately, remember again, ocular signs in the disorder are common. And approximately 90% of these patients with Fabry disease have corneal opacities, while 2/3 of the patients have conjunctival vessel tortuosity. So that thing they are now showing is those conjunctival vessel tortuosity.
All right, sir. Thank you very much, sir.
God help us. When I saw it, I actually thought it was lower.
Okay. Yes. And then that white area, is it looking like the cotton wool that we are talking about?
Don't know. I don't see. Yeah, what I know, I've seen tortuosity. Yeah. 616 to 619. Match the following descriptions with the appropriate association. A. Turner syndrome. B. Noonan syndrome. C. Both. D. Neither. 616. Coarctation of the aorta. 617. Normal karyotype. 618. Pulmonic stenosis. 619. Short stature web neck. Webbing of the neck, skeletal anomalies, and renal abnormalities. I think that's a short stature should go for Turner syndrome.
Yes, I agree with you,
Why
sir.
not both? Okay, Noonans are taller.
Noonans are tall, I think.
Yeah.
The normal karyotype.
I think Noonas are Noonas.
Those are short too.
What do you say?
They're short.
But I think they are taller than Noonas.
Okay.
Okay, eventually we'll read the answer now.
Yes.
Coarctation of the aorta.
That should be Turners.
Turners.
Turners,
That
turning
is
the
not both. Both.
Okay, we'll find out today. Pulmonic stenosis.
Noonans.
As it was just explained.
We
Yeah.
just said.
Pulmonic stenosis, Noonan. Okay. After when are we going to stop our people?
Let's just finish this blog and stop. What do you think, our people?
All right.
Because it's like just 5 people remaining.
The Chief Sawa is there. He's just not talking. You hear his voice now. Dr.
5 willing people.
Yes, madam.
You see now? Oh, Chief Conte is there. They are just not talking. I know.
Sorry, Conte.
I'm trying to stay awake. That's why I'm talking, actually.
Yeah. All right. Could you please help us read the answers, please?
Okay, let me quickly go through. 616 that's coarctation of the aorta is A, that's Turner syndrome. Then since Madam, why are you discouraging me?
I'm saying, hey, we got it.
Okay. 617, the normal karyotype, the answer is B, Noonan syndrome. 618, pulmonic stenosis. Fortunately, again, the answer is B. That's Noonan syndrome. We saw it somewhere up there. 619. The answer is both.
Wow.
I think yes. Remember again, if we go back again, we talked about webbed neck for Noonan syndrome. Is it not where we talked about that webbed neck?
Yes, they both have web neck.
They were, if you remember, at least I've seen a Turner syndrome patient. I've not seen that. I know they have webbed neck.
And they're
So
usually
the answer is, they're
very
also short.
Okay.
So let me, if there's anything interesting, I think that summarizes it. It's a short listing. They said the Turner and Noonan syndrome share several superficial features, so that we note these. Turner and Noonan, even if we don't remember, Turner and Noonan shares superficial features, including short stature, webbing of the neck, skeletal anomalies, renal anomalies, and congenital heart disease. Oh, that makes it better. So Nona and Turner, Nona and Turner. Okay. Because of these clinical similarities, Noonan syndrome is frequently referred to as male Turner syndrome. Are we clear? Or as Turner phenotype with normal chromosome. Okay. However, there are several striking genetic and clinical differences that can readily distinguish these two. Turner syndrome occurs exclusively in females. In approximately 50% of patients, the karyotype is 45X0. The remaining patients are mosaics with various other X chromosomes abnormality. Most fetuses with the 45X0 chromosome abnormal. Okay, most 45X with chromosome abnormalities. Form of Turner syndrome die in utero. Of those who survive, cardiovascular abnormalities occur in 35 to 50%. Coarctation of the aorta is the most common cardiovascular lesion for Turner syndrome. Other abnormalities include bicuspid aortic valve, the hypertrophic cardiomyopathy, atrial septal defect, mitral valve prolapse, and dextrocardia. Stenosis of the pulmonary valve is rarely seen in Turner syndrome, in contrast to Noonan syndrome. At least we picked the difference now between the two. In Noonan syndrome, we have the pulmonic stenosis. That distinguishes it clinically from the Turner syndrome. While for Turner syndrome, they mention its own distinguishing features, coarctation of the aorta, which is not seen in Noonan syndrome. So going forward again, they say Noonan syndrome appears physically similar to Turner syndrome. However, as indicated in answer to question 607 to 611, affected patients have a unique facial appearance with hypertelorism, strabismus, small chin, and low set ears. It is inherited as autosomal dominant trait. And then, in contrast to Turner syndrome again, both male and females are susceptible in this condition. The karyotype in both sexes is normal. So the karyotyping is normal for Noonan syndrome. In many families, the genetic abnormality maps to chromosome 12q24. Approximately half have a mutation in the PTPN11 gene in that region. Well, 50% with Noonan syndrome have congenital heart disease. The most common lesion is valvular pulmonary stenosis, as we already mentioned. I think these are the most important characteristic difference. We've noted the coarctation of the aorta. We've also noted the coarctation of aorta for Turner syndrome, the pulmonic stenosis for Noonan syndrome. But importantly, both two of them have a lot of physical similarities as mentioned. But remember again that the Turner syndrome affects mostly the female, while the Noonan syndrome affects both male and female. Thank you.
Thank you, sir.
Sorry, also mention mitral valve collapse for Turner syndrome. Did you mention anything like that?
Hello, can I hear you?
They didn't read it that. They didn't read up that. So.
He did.
No, I didn't
He did.
mention that.
Collapse
For
for
Turners.
for Turner. Okay.
Yes, he
Okay,
mentioned MVP and some other things.
Okay. Yeah. Yes.
Okay. So, but there's no mitral valve collapse for Noonan.
No.
Let me.
MVP for
did I
Turners.
mention?
MVP for Turners.
I didn't mention that.
And you read out plenty things for Turners. You
That's
read
why I
out
heard
plenty
let
things for Turners.
me go again.
you read it. I heard you.
Of those include bicuspid. Well,
There's
other
MVP
abnormalities
there. There's
include the
MVP
bicuspid
there.
aortic valve, hypertrophic atrial septal defect. But yeah, there is MVP there. MVP is there.
Thank you very much, sir.
Sorry, I want to confirm. Is it known as that is both males and females, right?
Yes.
Yes.
Okay. Thank you so much, Chief Examiner.
Okay. Question number 620 to 624.
I thought we were closing.
We are about to close. We just want to finish this blog, ma. Kindly permit us.
No, go ahead.
Thank you, ma.
All right. By the popular vote, I proceed. 620 to 624. Match the following descriptions with the appropriate parts of Fig 4.34. A is part A, B is part B, C is both, D is neither. This is the echo again. A is what is looking like, I don't know whether that is endoscopic radiography. I don't know.
At least they label right ventricle here, so I don't know
Yes.
whether it's it. I don't know whether it is. Hello.
Yeah, I can hear you. Can hear you.
Okay, I said I can't see them labeling a right ventricle here, so I don't know. Maybe it's a single ventricle. I wouldn't be too sure. I'm not so sure. That's for panel A. Panel B is looking like open.
Panel B is looking like that spade-like appearance we thought of the other time. Okay, let's see what they have in the options.
Yes, sir.
They are really fighting sleeper there.
We'll have to fight it. We still have a lot to do.
620, a ventricular septal defect typically accompanies disanomaly. 1. 621, detransposition of the great arteries is known to accompany this anomaly. 622, coronary variations in this disorder include abnormal origin of the anterior descending artery from the right coronary artery. 623, cyanosis and electrocardiographic finding of left ventricular hypertrophy are typical. 624, the Fontan procedure may be a useful intervention in this condition. So with this now, I think
Are you sure it's not a hypoplastic right ventricle? I don't know, just thinking out loud.
My dear, if I'm the one in this exam, I'll take all A. All of them. That's their
Jesus. Oh God.
I don't know. Chief Conte.
This 24 will be A. From
Chief
what Prof
Conte.
taught us, at least we can see one ventricle.
Yes.
Exactly.
From what he taught us,
Yes.
one ventricle. Fontaine's procedure.
Yes. Okay. So that means 620 and 624 might be AA.
Can we please read the answer? Please, somebody read the answer, please.
Okay, let me quickly go. Let me quickly go through the answer. But before I go through the answer, let me just read a very brief. The two-dimensional echocardiogram in part A of the figure displays an apical four-chamber view of tricuspid atresia, demonstrating a dense band in the tricuspid annulus. That white area is the dense band in the tricuspid annulus. And then an enlarged left
Chief,
ventricle.
can you use the cursor to show us?
It's not that place, so it's that place above the array. That place above the array that is white.
Yes, that's the one I'm talking about.
No, to your left. Above the array that is white. Yes.
Below. Yeah.
Yes.
Are we sure?
Yeah. Yes, demonstrating a dense band in the tricuspid annulus. That's where we have the annulus of the tricuspid. It's a apical four-chamber view.
Okay.
I think that's the place. Yes.
Okay, right? Yes. Okay, thank you. I think my head is
This anomaly is marked by the absence of the tricuspid orifice with an atrial septal defect, right? And then we can even it's not it's a continuous distance. So with an atrial septal defect, then usually yes.
There is no interatrial septum here.
There is no interatrial septum. Yes, that's what I'm
defect.
So as I said, this anomaly is marked by the absence of the tricuspid orifice with an atrial septal defect, which usually a hypoplasia of the right ventricle. So in tricuspid atresia, there is hypoplastic right ventricle, an atrial septal defect, and then fibrosis of the tricuspid annulus. So these are the three things that characteristic with tricuspid atresia. The other ones they talked about are stories, right ventricle, and then a communication between the ventricle, typically via there is also a ventricular septal defect. So four things that we are seeing in tricuspid atresia now. We are seeing a hypoplastic right ventricle, and interatrial communication, interventricular communication, and then fibrosis of the tricuspid annulus. Now, in 60% to 70% of the patients with this condition, the great arteries have normal relationship. The remainder have the transposition of these vessels. In addition, pulmonary stenosis or atresia may be present. Clinically, the marked diminution in pulmonary blood flow usually leads to severe cyanosis. In those infants in whom transposition coexists with a ventricular septal defect and an unobstructed pulmonary outflow tract, torrential pulmonary blood flow will occur, leading to heart failure rather than cyanosis as the predominant problem. All right, now let's look at the other one. The other one's echocardiography examination in this disorder is usually diagnostic. Then they talked about the cardiac catheterization. Now let's look at the other echo. The two-dimensional echo in part B is a parasternal long axis view of tetralogy of Fallot. So it's not what we It's not Hokun we talked about. It's a parasternal long axis view of the tetralogy of study, which demonstrates one, the aorta overriding the interventricular septum. Maybe we can be using the arrow to show that the aorta is overriding the. Can we see where the aorta is overriding the interventricular septum?
Aorta here.
Overriding
the interventricular septum here.
Yes.
The overriding is that part. There's a VSD. Then you can see that there's something coming from the right and left, then going into the aorta. So that's the overriding.
Ah.
It's a VSD. There's a VSD here.
Can we see that?
Ma, please, where?
Okay. On just at the
Look
Just
at
by
the
the aortic,
aorta.
at the
by
right
the
hand
aortic
corner.
opening.
Yes, that's
Okay,
what
okay,
character.
okay.
So it's draining from both right and left into the aorta. So
Take
overriding.
it to your right a little.
To your right, yes.
Yes. Okay, that's good. So the aorta overriding the interventricular septum 2, a ventricular septal defect.
Yes. There's a VSD.
Is that not the ventricular? Where the arrow
No.
is that not the VSD?
See, it's because of the VSD. That's why there's an overriding. So there's a VSD. Then the aorta will now come and cover the VSD so that from both chambers it will be going into the aorta. That's the overriding.
Okay.
VSD.
It's under yes. It's understandable now. Then we said A, the aorta overriding the interventricular septum, then 2, a ventricular septal defect. Then the two other components that comprise the malformation are 1, right ventricular outflow obstruction, and then right ventricular hypertrophy. So are we seeing it here? Not
Sorry,
really.
beneath the, is it the posterior wall? It's as if, I don't know if there's a left ventricular aneurysm, or I don't know what that is. That's beneath the posterior wall.
Okay.
Hello? I don't know, are you seeing something like a hypoechoic, like beneath the posterior wall?
Yeah. I can see it.
Yes.
There. What do you think that is? It's just gone. Thank you.
Is that not a dense? Okay, they didn't mention anything about that here.
Okay, okay, that's fine.
Okay, so let's with this background now we can go to the answer session. Now 620, the ventricular septal defect typically accompanies this anomaly. So the answer is C.
Answer is what?
Which is C, both of them.
Okay.
If you remember what we said about tricuspid atresia, it has both interatrial communication, interventricular communication, left ventricular hypertrophy, the tricuspid annulus fibrosis, and then these are the four things that so these are the four things we've mentioned already. Now, 621, the transposition of the great arteries is known to accompany this anomaly. And of course, we also mentioned that, he said.
That's A, we mentioned that in A.
Yes, that's A, we mentioned that in A. That's A. The answer is A. Then 623 again, cyanosis. We also mentioned that in A. Cyanosis and electrocardiography finding of left ventricular hypertrophy. He's even looking at us here. We mentioned that in A also. 624, just as the person that said she will take A for all the answers. A is going for all the answers except for 620. 624, the Fontaine procedure is still A.
You jumped
What's
622.
622, sir?
622. Oh, we jumped that. Okay. We already know the answer from what we read. Coronary variation in this disorder include abnormal origin of the anterior descending artery from the right coronary artery. We didn't read that. Is 623 is B.
Is it B or A?
Is B.
All right, sir.
Is
So,
B both? I can't see B option. B is both.
No, B.
Or is it
B
B? Is B
is
both or
B.
A?
No, B is
COF.
part B. B is the tetralogy of allele.
COF. Okay.
Okay. Thank you very much, Chief Examiner.
Can we call it day? Can we call it a day? Yeah, my eyes are doing me somehow.
Let me help you read the last part. It's just 3 questions now. Abba. What do we say? Let me read it.
Let's right. Question 625 to 629. Match the following complications with the associated anti-neoplastic therapy. A. Thoracic radiation therapy. B. Anthracycline therapy. C. Both. D. Neither. Pericarditis. I know for this one that radiation causes it. I don't know about anthracycline. Premature coronary arteriosclerosis, anthracycline causes it. Left ventricular systolic dysfunction, anthracycline causes it. I don't know about thoracic, I don't know about radiation. Ventricular arrhythmias, both can actually cause it. Aortic dissection, irradiation will cause it. Please, contributions and comments, please. Hello, am I audible?
Yeah, audible. Dr. Briggs, contribution and comment.
Okay. For anthracycline, that left ventricular systolic dysfunction, it actually occurs, but it occurs later. It's a late complication. So it starts with diastolic dysfunction, and over time, the patient will now start presenting with left ventricular systolic dysfunction. So I think I agree with all your options. I don't think anthracycline will cause aortic dissection. I think thoracic radiation would, but I think anthracycline can cause every other thing aside aortic dissection. That's what I think, Sha. Let's just check the answers.
Is that our final answer for 629? Do you all agree? Do you all agree that
you want to call a friend?
Well, let's now go to the answer and see how correct we are. 625 pericarditis is caused by A, that's the radiation therapy causes it. 626 premature coronary arteriosclerosis is also caused by the same radiation therapy. That's A again. 627 left ventricular systolic dysfunction is caused by, of course, it has to be pharmacotherapeutic agent. So it's caused by anthracycline therapy. That's B. 628, the same ventricular arrhythmia, the same pharmacologic agent is also going to cause 628. That's B again. Unfortunately, our final answer in 629 didn't clear the answer. The answer is still stuck there. So 629 is neither. D.
Wow.
Okay, so let's see any brief why they chose neither as that. Aortic dissection is not associated with these ethnoplastic therapies. But briefly, let's say radiation therapy and chemotherapeutic agents both have potentially serious cardiac adverse effects. Cardiac exposure may occur as a result of therapeutic radiation to the lungs, breast, or esophageal cancers or mediastinal radiations for lymphomas. So you see, any of the exposure for this can cause cardiac abnormalities. But one thing is going another. We are not looking at radiations deals more with some structural issues than functional issues. All cardiac structures are susceptible to radiation damage, especially the pericardium, but also the myocardium, coronary arteries, conduction system, and valves. The effect of radiation on the pericardium may be acute, for example, hemorrhagic effusions, or delayed for several years, fibrosis with constrictive pericarditis. Radiation therapy is also a cause of premature coronary artery disease. Yes. Retrospective studies have demonstrated that children treated with radiation therapy for Hodgkin disease have a significantly increased risk of developing symptomatic coronary artery disease at an early stage. Radiation-induced myocardial fibrosis is common and may lead to restrictive cardiomyopathy. Radiation effects on the conduction system may cause sinus node disease and atrioventricular block. Radiation exposure of the aortic valve and the papillary muscles have been implicated as a cause of regurgitation of the aortic and mitral valves. Anthracycline chemotherapeutic agents can have an acute direct toxic effect on the myocardium, resulting in ventricular and supraventricular arrhythmias, as well as conduction system blocks. More commonly, cumulative exposure to anthracycline results in a chronic cardiomyopathy, especially at a total cumulative dose greater than 400 milligram per meter square. Rare cases of acute myocarditis, pericarditis within 2 weeks of anthracycline therapy have been documented and described. Aortic dissection is not associated with these retinoplastic therapies.
Oh, thank you.
Very much, sir.
Thank you,
Thank you.
sir.
Thank you.
Thank you.
Well appreciated.
Yeah. Chief, it's okay. Over to you. Me, I want to go and sleep. Oh. But I know
So
that
two more remaining. Two more blocks remaining.
Sir?
Two more.
Ha.
Hello.
What did you say, sir?
Chief Examiner, sir. You said something, sir.
No, we have 2 more blocks remaining.
Yeah. You are the Chief Examiner, sir. Whatever you say, sir.
No. you initially said 3, only 3 more blocks remain. So we have done 1.
And then
Actually, we finished all the blocks in the question, and sincerely, I appreciate everyone for allowing us to push together. Although the mandate they gave us was that by 31st of January that we should have finished the whole of Braunwald. But the fact that some people did not read their parts and they did not also get back to us, that they've not been able to go through it, really dragged us back. Now we still have questions 511 to 549 left undone. And I think like 20 questions in 600 to, no, in 641 to 670 that we've not done, making a total of about 80 questions remaining. So going forward, I don't know how we are going to tackle that because we are supposed to begin Prof's book this evening, but maybe we'll hear from them and whatever we decide, if you want us to first finish Braunwald and then we start Prof's book, or if those people can actually read their parts, it will make things easier for every one of us. But I've sent messages, no response, they are not reading it. So maybe we are the one that will also do it together. I don't know. Those are just my thoughts. It depends on what all of us decide on. Yeah, but Chief.
Okay. Yeah. Let me. I think what we'll do tomorrow, if they are not done, we can. Hello.
Pardon?
Chief exam. Okay. They said we should stop the recording, sir. Chief Sawa, sir.